Now, we are about to begin the BREM Board Reviews in Emergency Medicine, where practical clinical knowledge means exam oriented discussion. Our first presentation is mechanical valve thrombosis, essential treatment modalities every EM physician should know. Please welcome Dr. Ananda Krishnan KS.
Good afternoon to one and all present here. So I will thank first the Aemecon team for giving me this opportunity. So my topic is missing a click mechanical valve thrombosis. So mechanical valve thrombosis, though it's quite rare, but it's a life-threatening complication that has to be addressed at the earliest for saving the patients. So today we are going to see at introduction, what are the clinical presentation, what are the diagnostic imaging that are available, the differential diagnosis, severity grading, management strategy, and evidence-based treatment, like what are the current trials that's been advised and what does it say. So if you look at this slide, you can know that the incidence is 0.1 to 5.7% per patient per year. So the thrombosis, post mechanical valve replacement, the thrombosis is highest during the first year. It can go up to 20% if a tricuspid valve has been replaced. And valve position. So it is more common in mitral than the aortic valve. And the leading risk factors. First, non-compliance of patient for taking the drugs so that the PTINR is not maintained. And the number of patients who are undergoing valve replacement has been consistently increasing with 850,000 projected by 2050. So what are the additional risk factors? Post mechanical valve replacement, the patient might have a atrial fibrillation, which is a prothrombotic state by itself. Along with this, previous thromboembolism, hypercoagulable state, and left ventricular systolic dysfunction. Valve design, so it is more common in tilting disc valve, so that has the highest among different types of valve. Tilting disc has the highest, and bileaflet valve, more commonly replaced in the aortic area, is also more prone for thrombosis. So what are the life-threatening signs and symptoms which they present? So the patient may come with a sudden onset obstructive thrombus, which may lead to a acute pulmonary edema. So any patient who comes with a pulmonary edema with a previous mechanical valve replacement, we have to think about the thrombosis of the mechanical valve. Along with that, the patient may have a cardiogenic shock, because non-functional valve, there will be a decreased cardiac output which may leads to shock. And patient may have a complete occlusion where the patient will sudden cardiac death and embolism from the pre-existing thrombus. So mitral valve thrombosis can present anytime after the surgery, even years later. So we need a higher suspicion for diagnosing it. So as I said earlier, the patient may present with acute heart failure, cardiogenic shock, and hemodynamic collapse. But as the journals say, it is a tip of an iceberg. In lot of patients, thrombosis will be present, but the patient will be having patient will be asymptomatic. The thrombosis does not comes and interferes with the valve function. Such thrombosis, it's underdiagnosed, so it's a tip of an iceberg. So the important clinical finding is, if you are going to put a stent in a patient, if the click is absent or muffled, then we should have a higher suspicion. So auscultation becomes one of the important thing for diagnosis of a valve thrombosis, because absence or a muffled heart sound carries a higher sensitivity and specificity for finding the thrombosis of a mechanical valve. So additional symptoms, as you know, patient might have dyspnea, fatigue, chest pain, orthopnea, syncope, and palpitation, which are all the symptoms of an acute heart failure. The hemodynamic impact, as I told, the patient may have a severe obstruction of the disc, or the thrombus will be interfering so that the disc does not close, because of which the patient might have a intravalvular jet regurgitation jet that might be arising, which may lead to heart failure. Along with that, the patient might have an intermediate symptom. So there are two types. One will be along the annulus, one at the tip of the mitral valve itself, mechanical valve itself. So one at the tip of the mechanical valve will be more symptomatic, and one around the annulus, that we call it as in chronic case as a pannus, which does not have more symptoms and it might be intermediate. So as you all know, the most common embolic manifestation, the patient may have a cerebral thromboembolism secondary to the thrombus present, and patient might have a systemic embolism such as thrombus to the peripheral arteries and mesenteric and the renal arteries, and coronary embolism, patient may have a acute MI. So these are all we should take into mind. Even a patient with a sudden onset heart failure along with a CVA, then we have to think the patient might have a thrombosis, and the thrombosis may be embolized to a distant organ, and this thrombus also forms the plate for vegetation. So patient might have symptoms of even infective endocarditis. So what are the diagnostic imaging available? So based on all the journals and meta-analysis, the first best mode is transthoracic echo. There are some disadvantages. The transthoracic echo cannot have a better look at the mitral valve or the atrial side of the mitral valve, for which transesophageal echo with a 3D reconstruction, real-time reconstruction is preferred. So transthoracic echo, what we do when the patient arrives, we put the probe and we look at the parasternal long axis and short axis view. So transthoracic echo has a good sensitivity and specificity for detecting the aortic thrombus rather than the mitral valve thrombus, but we can, by just looking at the echo, we might know that there is a restriction of movement. So the best method, what they say, is superior transesophageal echo, which has a superior resolution, especially for the mitral prosthesis. It has a 81% sensitivity for mitral valve thrombosis detection. Next is sign fluoroscopy. This is particularly used to differentiate pannus from mitral valve thrombosis. The fluoroscopy says more about the movement of the leaflet rather than the thrombus. So based on at what angle there is an occlusion because of the thrombus, how is the movement of the leaflet can be assessed using the sign fluoroscopy. And what they say is MDCT has the best of everyone. It has highest sensitivity, it has highest specificity, it has the best positive and negative predictive value also. So how do we differentiate the thrombus from a pannus? You know, we put the Hounsfield unit. When the Hounsfield unit is more than 200, it's a pannus, which is a chronic calcification like thing that develops in the mechanical valves. But if it is less than 200 Hounsfield, then we will take it as a thrombus. And post lysis, see, one of the treatment for mechanical valve thrombosis is either replacement of the valve or lysis. So post lysis, the Hounsfield unit will be reduced to 90 Hounsfields. So the diagnostic algorithm is, for initial assessment we will use transthoracic echo and clinical evaluation. For thrombus characteristics and mass differentiation, we will be using transesophageal echo with multi-detector CT, and fluoroscopy is for leaflet motion assessment. So for transthoracic or a transesophageal echo, what we do is, after the post surgery, we will be doing an echo and we will be noting all the flow and non-flow parameters after 1 month of surgery. That is taken as the baseline. With any changes from that baseline value, we have to think about thrombosis. So how to differentiate a thrombosis from pannus? This differentiation is important because pannus, the treatment is either the replacement of the mechanical valve itself, but thrombosis, based on the size, we can go either for a lysis or we can increase the PTINR ratio for a smaller thrombus, and for a larger thrombus we will go as like pannus, we will go for a replacement of the valve. So chronology, thrombus is acute, it can happen anytime But for a PANAS, it will take at least a year, usually more than 5 years. Whenever the PTINR is decreased and there is a sudden worsening of symptoms, then we have to think about thrombosis, because it has a stronger correlation with anticoagulation. And the location is, it is more in mitral, and in mitral it is either supra or subvalvular. PANAS is more common in aortic, in the subvalvular area. And the morphology, as thrombus, it is large, irregular, attached to valves or hinges, and it is centrifugal. It starts from the center and spreads to the periphery, while in PANAS it starts from the periphery and it goes to the center. So esophageal echo detection, it is 100% for a thrombus, but often it is undetected for PANAS. For PANAS, we have to do a MDCT to find the PANAS. And the echo density is less than 0.4 for a thrombus and more than 0.7 for a PANAS. As we discussed earlier, the orifice, it's more common in mitral in case of thrombus, and PANAS, it is more common in the aortic area. And Hounsfield unit, less than 200 is for thrombus and more than 200 for PANAS. So for severity grading, it's to be easy, we will do this semi-quantitative parameter where the pressure half-life, we will be putting a continuous wave Doppler through the mitral valve, and if the pressure half-life is more than 200 milliseconds, we can take this as a severe mitral valve thrombosis. And also we can see the surface area. If the surface area is less than 1 centimeter or change of surface area from the baseline of more than 0.35 centimeter, we can say the patient is developing a thrombosis of the mechanical valve. Along with that, if we can put a continuous wave Doppler, and if you can track the velocity time integral, we will get the maximum velocity, which is more than 2.5 seconds, and the mean gradient, mean pressure we will be getting. If it is more than 10, then we also have to think that the patient is having a severe mitral valve thrombosis. So when it comes to aortic, we are going to use different parameters in echo, where the acceleration time. So there will be two peaks if you put a continuous wave Doppler through the LVOT into the aorta. So from the start to the peak, whatever is the time is the acceleration time. If it is more than 100 milliseconds, we will be taking that the patient is having a severe aortic valve thrombosis. And acceleration time to ejection fraction time, peak ejection fraction time, if the ratio is more than 0.37, then also we will take this is a severe aortic valve thrombosis. So management strategy, for if it is a non-obstructive, if the thrombus size is less than 5 millimeter, we will be using unfractioned heparin or low molecular weight heparin, because it has a fewer complication. For larger thrombosis more than 10 millimeter, we will be either considering a surgery. So what is the target INR? Actually, there have been different guidelines through the meta-analysis, but one trial says to maintain at 2 to 2.5 rather than 2.5 to 3.5 to have a decreased complications of maintaining a higher INR. And the anticoagulants of choice is unfractioned heparin until therapeutic INR or LMWH, which is less thrombolytic. DOCA previously was not recommended, but it has now been considered in various trials for treatment. For obstructive mitral valve, when the NIHA, National New York Heart Association breathlessness score is more than 3 or 4, or patient is having a cardiogenic shock, then we will go for a surgery. If the patient is having NIHA 1 or 2, we will be, or a small clot, we will be first try to dislodge it by doing a thrombolysis. If it is not successful, we will go for a surgery. So first we have to assess the hemodynamic status, evaluate the thrombosis characteristic, calculate the surgical risk, check the contraindication, and have a discussion, and you can find what has to be done. So in the meantime, we can have a bridge to surgery where a transcatheter option of lysis can be done. So what are the different thrombolysis that are available? The TROY trial says 25 mg over 6 hours. But the PROMET trial says 25 mg over 25 hours. When we are comparing both TROY and PROMET trial, the sensitivity and specificity and the outcome was good in Promet trial where 25 mg was over 25 hours was best. So for a lysis, the success rate was 90.4 in Hatashu trial, which has a ultra slow Promet like infusion. In Troy trial, where 25 mg over 6 hours, it was 85.5% successful rate. The complication was less than 2% for major bleeding and less than 2% for major embolism. So for whom we are going to contraindicate, if there is a left atrial thrombus, ischemic stroke within 3 weeks, history of hemorrhagic stroke, active bleeding diastasis, and the relative contraindication was INR more than 3. So once you lyse the patient, we have to start the patient on a heparin for 24 to 48 hours, and we have to maintain the PTINR of 2.5 to 3. So we are going to do serial trans esophageal echo or transthoracic echo, and we are going to assess the size, whether the size post lysis has been reduced or not, monitor the different gradings to transthoracic echo, repeat TPA if needed, and as I said before, we have to start the patient on heparin post lysis. So these are the recent advances. Protract trial, as I told, if the thrombus area is less than 0.8 centimeter, it says the patient will have a fewer complication. Troy trial says low dose 25 mg over 6 hours has a successful rate of 85.5%. And Promote trial says it has a higher success when compared to 25 mg over 20 hours, that is 90% success rate. And as I told, Hatashu trial, what does it say is thrombolysis is better than surgery because the mortality is more when compared to the thrombolytic. And PROACT trial is on whether we can use DOCA, but it was discontinued because the patient started developing thromboembolisms when the patient was put on DOCAs. So the trial was stopped in between. So the role of direct 10A inhibitors are still not been studied. So as I said, for whom we have to do surgery and whom we have to fibrinolysis, if surgical expertise is available and low surgical risk, if there is a contraindication for thrombolysis, if the patient is having recurrent episodes and having a worse score, that is NIHA 3 or 4, when the clot size is more than 0.8 centimeter, patient is having a concomitant coronary artery disease where the patient has to undergo a cardiac surgery, or if there is a PANUS. So the key takeaway are, we need a higher index of suspicion. Any patient with a breathlessness with a mechanical valve replacement history, particularly rheumatic heart disease, is quite common in India, so we have to auscultate. So if there is an absent click, then we have to do a transthoracic echo. That is the first modality of investigation of choice. And we can, if it proves or if we have a doubt, we can go for further with transesophageal echo, CT fluoroscopy. So the treatment is based on the size, where it is situated, whether it's a PANUS or a thrombus, decides whether the patient has to undergo a surgical or a thrombolytic therapy. And as I said, PROACT 10 trial, where apexaban was apexaban versus warfarin was tried, and it was discontinued because the patient who had an apexaban had increased thromboembolism, so it was discontinued. And trans catheter technique, where directly a catheter is placed and it is directed, and just above the thrombus we are going to use a low dose thrombolytic therapy, that has been tried. And embolic protection during thrombolysis to reduce the stroke risk. Thank you. So if time permits, sir, I have a case. Can I? Yeah, thank you, sir. So this was a real case that presented to our ED. It was a 60-year-old male with a history of rheumatic heart disease for which a mitral valve replacement was done 2 years ago. And the patient was on irregular treatment and anticoagulant. The chief complaints was sudden onset breathlessness. Duration was 3 hours and a chest pain associated with palpitation. So, a acute presentation with sudden onset symptoms in a patient with mechanical valve required immediate evaluation because we might lose the patient. So, as far as emergency is concerned, we followed the ABCDE. If you see at the breathing, the saturations were low and the patient had a bilateral fine Krebs, which was showing that the patient was having a acute failure, heart failure. So, patient was put on an NIV and a PEEP of 5. His blood pressure was normal, but the heart rate, the patient was having a tachycardia. And his GCS was normal and the blood sugar levels were normal. So, when we did a diagnostic, there was a T-wave inversion in one AVL V2 to V6. So, we sent it for the blood investigation, ABG, LFT, electrolytes, CBG, RFT and coagulation profile. When we saw particularly the PTINR was very less, it was not on the targeted of 2 to 2.5. The patient had a sinus rhythm and a normal axis. When we looked at the IVC. So the IVC was more than 2.5 centimeter, less than 50% collapsible. So it was probably due to the regurgitation or the mitral valve stenosis that was occurring because of the thrombus that was obstructing the mitral valve. And the patient was having an acute heart failure. For that, he had bilateral B lines on lung ultrasound. And his ejection fraction was 40, which was a moderate ejection fraction. And as you can see the picture below, the mitral valve mean gradient was 15 and the pressure gradient was 27, which was pointing towards mitral valve thrombosis, and there was a restriction of movement when we did a transthoracic echo. So immediately, as we did not have a transesophageal echo at that time, we have to get the cardiologist opinion. In the meantime, we had when we had a detailed history in secondary sample history, we had a breathing difficulty with a NIHA class 3, chest pain left sided and no allergy. And in respiration, as I told before, the patient had bilateral fine Krebs. And the patient, we did not hear a click. The click is very important for any patient who have undergone mechanical valve replacement. So, as I told, patient was given a bed rest with a position for comfort, non-invasive ventilation. Patient was started on digoxin and Lasix for the pulmonary edema. Patient was already on erythromycin for that has been either we give the penicillin 250 mg BD dose or the erythromycin for any rheumatic heart disease patient who have undergone the replacement. And we started the patient on altiplase, that is 25 mg IV infusion over 6 hours. And post infusion, we started the patient on heparin. A 24-hour post lysis transthoracic echo revealed that the patient dyspnea was settled and the parameters, the previous parameters of the mean gradient and the pressure gradient were coming back to normal, and there were the previous restricted movement of mechanical valve was not seen. So there was an early improvement, and the patient was post echo, the valve opening was normal, MVMG was 7 and MVPG was 11, and the EF from 40% it came back to 50%. It is a normal left ventricular ejection systolic fraction. Then we switched the patient to warfarin and we followed up the patient to maintain an INR of 2 to 2.5. During my post graduation, what I feel is if we are in a setup where altiplase is not available in India, quite few government setup does not have an altiplase. We can do a streptokinase lysis where 1.5 to 2.5 lakhs a bolus is given, followed by 1 lakh units per hour for 23 hours or 24 hours. So I saw such a case during my post graduation, and that case also recovered very well. So if we don't have an altiplase at our workplace, we can use also streptokinase. So as I said before in the previous, the success rate of ultra slow infusion 25 mg over 24 hours 90%, and complication was less for ultra long infusion 6.7%, and the mortality is lower than surgery of 0.8%. Thrombolysis has a mortality of 6.6% when compared to surgery of 18 to 45%. So whenever we see a case of mitral valve thrombosis, it's not that the patient has to undergo a surgery immediately to replace the valve. So we have to confirm whether it's a thrombus or a pannus. And if it is if the patient is fit to go for a thrombolysis, it is better to thrombolyze the patient rather than to take him up for a surgery. Thank you.
Thank you, sir. For the BREM session, we have Dr. Venkat Kotam Raju as the moderator. Coming to the next session, we have the VOC code, Emergency Approaches That Matter by Dr. Guglod Ramesh Babu.
Guglod Ramesh Babu, MD Emergency Medicine, Assistant Professor, ESIC Medical College, Chennai.
Good afternoon, everyone. Myself, Dr. Ramesh Guglod. Today, my topic is vaso-occlusive crisis. Vaso-occlusive crisis. Okay. So before going to the topic, we will just go with some of the basics here. So hereditary anemias, whenever we see about the hereditary anemias, mainly because of the defect in the hemoglobin production, or because of the RBC metabolism defects, or because of the changes in the membrane structure of the RBCs. So if you can see, mainly hereditary anemias are of two types. One is the sickle cell anemia, is mainly because of the structural defect, and the thalassemia is because of the production. These basics and all we know already. And if you see the basic hemoglobin, the fetal hemoglobin you can see, which is having the two alpha chains and the two gamma chains. Generally, whenever we speak about the hemoglobin, there will be two components. One is the heme, one more is the globin. Globin chain will be like 4 types of globulin chains we have. That is alpha, beta, gamma, and delta. So fetal hemoglobin will be formed with the alpha and the gamma, and the adult hemoglobin will be formed with the alpha and beta. And what is sickle cell trait? In the sickle cell trait, if you can see, alpha hemoglobin, alpha chains will be normal, but one of the beta chains will be having some point mutations, and one beta chain will be normal. So that is HBS, which is a sickle cell trait. And if you speak about the sickle cell chain or the sickle cell disease, both beta globulins will be defective, point mutated. So you can see it here, the basics. So the here on the 11th chromosome, 6th position, okay. So you can see it here. The adenine will be replaced by the tyramine. That's the reason why the glutamate will be changed to the valine. So which is the defective beta globin chain. So if the two chains are defected, in that conditions you can see the sickle cell disease. Okay. So if we look into the epidemiology, both in India and globally, the sickle cell disease is one of the major public problems. So sickle cell variants first reported in southern part of India in 1952 in Nilgiri Hills, and past 70 years there have been so many studies and the published literatures are there about this sickle cell disease, and it is a burden on the public healthcare system also. So that's the reason why the government of India and and they have formulated the national guidelines for managing the sickle cell diseases and the complications related to the SCD. Okay, so here in this slide you can see globally and at the same time in India also. So from 2000 to 2021, like a 13.7% raise in the sickle cell diseases in worldwide. In India also. In India also, there are like multiple areas where the sickle cell disease is very much prominent. You can see in few of the areas like Madhya Pradesh, Chhattisgarh, Maharashtra, Orissa, and Kerala, Tamil Nadu, and the Telangana states are like most affected states. So the wide variety of cases, like wide variety of the distribution is there. So starting from the 1% to 44% depending upon the areas. And an average you can take in India, 4.3% prevalence is there all over India. So the national guidelines say that whenever you want to diagnose, so you can follow the two-step criteria. One is like directly you can go on to do the confirmatory test. GOI is nothing but Government of India approved point of care test, which is the confirmatory test. Or you can go with the screening test and then the confirmatory test. So in the screening test, you can use the solubility test where you can screen the mass public when you want to see whether the sickle cell disease is prevalent in the particular community or particular area. You can go with the solubility test as a screening test, and if you can find it is a positive, and you can go for the confirmatory test for the confirmation. Okay, so solubility test is a test tube based, which is like very much inexpensive and no experience is needed. So whenever you take blood sample from the person with a very little amount of blood sample and you mix it with the sodium thiosulfate, which is a reducing agent, hemoglobin reducing agent, there will be turbidity will be there. If the turbidity is there, it is sickle cell positive. If the turbidity is not there, only clear test tube is there, it is negative. Okay, if you are thinking that it is a positive because of the turbidity, you can go with the point of care confirmatory test. This is what we generally, Government of India recommends to do in the public for the mass screening. In confirmatory test, once you do the solubility test as a screening test, if you want to do the confirmatory test, you can do the point of care test. And apart from the point of care test, we have other tests like high performance liquid chromatography and capillary zone electrophoresis and gel electrophoresis. These are all diagnosing the sickle cells only. Okay. So whenever you suspect, like if the people, if they want to conceive, prenatal diagnosis is required or not, that is very much important, which was taken from the national guidelines. So you can see the right side, if you can see left side, prenatal diagnosis is required in those cases where if the sickle cell disease individual and the sickle cell trait individual are getting married. As we know, sickle cell disease is autosomal recessive, isn't it? So you can see in this slide, if the two sickle cell traits are getting married each other, 25% of the babies will be normal, 25% will be the carriers, and 25% will be the sickle cell disease. In this condition, you have to do the prenatal test is mandatory if they are planning for the pregnancy or the patient is conceived. Okay, because to diagnose whether the sickle cell disease is there or not prenatally. If the sickle cell disease is there in the baby, then whether the continuation of the pregnancy depended upon the parents. Whether they want to continue, they can continue the pregnancy. If they don't want to continue, they can take a call on that. So that's the reason why we are going to do the prenatal test. If you can see the second scenario where one is a carrier and the second person is a normal individual. In this condition, 50% will be normal and 50% will be carrier. So in this condition, there is no problem in continuing the pregnancy. So you need not do preterm diagnostic test for the sickle cell disease. Okay. And in the third scenario, if you can see, one is a diseased person and one is a normal person. In that condition, 25%, all 25%, like everybody will be like sickle cell carriers only. So in those conditions also, you need not do sickle cell testing. Prenatal sickle cell testing is not required. Okay. So mainly, so these are the basics, like how to, where and all the predominantly sickle cell is present and what are the confirmatory tests recommended by the Government of India. Now, ED perspective view, like if you want to see as a ED physician, how the patient will present to emergency department, that we will see to now. Okay. Most of the times, acute complications of sickle cell disease because of the infections, severe anemia, vaso-occlusive phenomena, and the complication related to the pregnancy. So the most common complication of SCD is acute episodes of severe pain referred to as vaso-occlusive crisis, which is a topic today. Okay, mainly 4 stages of the disease progression will be there if you are speaking about the VOC. So one is a prodromal stage where we'll be having the very minimal symptoms, and the initial stage, established stage, and resolving stage. Either resolving will be there or the patient may go into the severe complications also. So mainly these symptoms and all will be lasting for the 10 to 12 days in hospital. Okay. So now the main pathophysiology involving the vaso-occlusive crisis is vascular dysfunction, inflammation, P-selective mediated cell-to-cell or the cell-to endothelial adhesions. So mainly whenever the patient presents to emergency, mostly because of the ACS, stroke, pulmonary embolism, or the splenic or the hepatic sequestrations, or else pulmonary hypertension, patient will be having these kind of features along with the pain crisis. So mainly if you compare all these, which is the more prevalent one, means pain crisis is the more one where we have to address as early as possible, and we have to formulate the specific guidelines for managing the pain for the sickle cell crisis. Okay, approximately 50 to 80% of the hospitalization in SCD is because of the VOC. So most common cause of mortality among the Indian patients, and reduces the quality of the life also. This I have taken from the one of the journals which I quoted here. And vaso-occlusive crisis as early as within the 6 months of age also patient may present with the VOC, and accompanying most commonly extremities, chest and the back are the most common areas where the pain will be there. So what are the triggering factors? Where the viscosity of the blood is increasing, there the vessels occlusion will happen. So where the vessel occlusion is happening, there the patient will be having the more pain. Like the conditions where you are getting exposed to the conditions like extreme stress or else infections, physical exercise or binge alcohol drinking or dehydration. In these conditions, if you can see, the viscosity of the blood is increased, so which will lead to the vaso-occlusive pain also. So whenever the patient with the SCD is presenting to emergency department, you can't directly tell that patient is having VOC. So whenever the patient is complaining some sort of pain in some region, you have to think about the differential diagnosis also. If the patient is having the bone pain, think about the other causes like osteomyelitis, avascular necrosis, abdominal pain is there, cholecystitis, cholelithiasis, groin pain, back pain, headache. So along with the evaluation of the VOC, we have to think about the different causes also, differentials also, and we have to address the same problems as well. Okay. So now if you go to the management, see, rather than treating the patient, like prevention is more better than the treatment, as we know that one. So whenever you diagnose the SCD patients, like sickle cell disease patients, you have to anticipate that patient may land up in vaso-occlusive crisis at any point of the time. So before that only, you try to prevent such kind of episodes. So prophylactic management has to be done if you are suspecting VOC in the patients. So mainly we'll be using the folic acid and the penicillin. Penicillin is mainly because of the hyposplenia. Generally, whenever the SCD patients or sickle cell disease patients are there, those patients will be having hyposplenia, more prone for the infections. So in these conditions, prophylactically, if you are giving the antibiotics, you can prevent the further complications of the sickle cell disease. So folic acid helps to prevent the deficiency because of the increased cell turnover, and there is a recommended dose also according to the national guidelines of the India and ICMR project. So if the patient is having more than 1 year of age, you can give 5 mg daily, and if the patient is below 1 year of age, 2.5 mg daily, you can give folic acid. As we were discussing, hyposplenia is one of the main problems in SCD. So prophylactically, you have to go with the antibiotics like penicillin V, where it is also the age based. If the patient is having less than 1 year, 62.5 mg, and if the patient is having more than 2 years, more than 1 to 2 years, 62.5, and more than 2 years, 125 mg per day, and if the 5 years, till 5 years, you can go up to 250 mg per day. Okay, and the immunization schedule has to be followed properly. Even though it is adult patient or else children, immunization has to be done properly to prevent the further infective complications. Okay, this is a very key drug, very much useful in managing the SCD for prevention of any of the complications. So hydroxyurea, which is a key drug actually. So it increases the fetal hemoglobin in the body. As you see, like adult hemoglobin will be having alpha and the beta chains. Mainly sickle cell disease because of the beta globulin defects only. But the fetal hemoglobin will be having alpha and gamma. So if you can increase the fetal hemoglobin in the body, the complications can be reduced. So the hydroxyurea, main thing is that only. It will increase the fetal hemoglobin in the sickle cell disease patients. So the complications can be reduced if you are using properly. Okay, and it also reduces the circulating leukocytes, which will decrease the adherence of the neutrophils to the vascular endothelium. Ultimately, the thrombus, whatever is forming because of the adhesions, will be reduced by using the hydroxyurea. So this also, like, there are multiple studies they have done actually about the usage of the hydroxyurea and what is the role in controlling and the prevention of the vaso-occlusive crises. So even the American Society of the Hematology is recommending, and the national guidelines and ICMR project is also recommending to use the hydroxyurea. But whenever you use, and this is the like meta-analysis, they have done 21 observational studies involving 3,378 adults. Overall, like, European Society of Hematology and American Society of Hematology, they have combinedly done the study, and ultimately they have shown that the hydroxyurea, whatever we are using, that is going to reduce the pain crisis in 60 to 90% of the cases, and hospitalization in 90 to 100% of the cases, and increases the fetal hemoglobin 4 to 20% in the body. Actually, it will present 1 to 1.5% in the normal human being, but it is increasing up to 4 to 20%. So hydroxyurea is mainstay of the drug in prevention of the complications mainly. So dose also they have mentioned, because hydroxyurea is having toxicity and the multiple complications, and continuous monitoring is required. So the dose has to be started at the minimal dose only. So if you are starting the minimal dose, and we have to see the effects, and we have to escalate the dose depending upon the close monitoring. So most of the studies are telling that 10 mg per kg has to be started, and we have to monitor the patients properly. What monitoring has to be done, I will tell you in the next slide. So if the patient is tolerating maximum tolerated dose of 35 mg per kg, you can go. So you can increase the dose every 2 to 3 months once. 5 mg per kg, 5 mg per kg every 2 to 3 months you can increase from 10 mg per kg to 35 mg per kg. Up to that level you can go. And anyways, in the CKD patients, you have to decrease the dose by 50%. Okay. This also I have taken from the national guidelines. So what they're telling, starting dose of the hydroxyurea is 10 to 15 per kg per day, single dose. And the follow-up has to be done every CBC follow-up has to be done, and the renal parameters and the liver toxicity has to be ruled out every time, 2 to 4 weeks once. And if needed, you can escalate the dose 5 mg per kg every time in 2 to 3 months once. And hydroxyurea, it is a teratogenic drug. So if the patient is planning for the pregnancy, or the pregnancy is like already confirmed, you have to stop the drug. It is contraindicated both in pregnancy and lactating female. So all these things we are discussing to prevent the VOC complications and VOC. So how to manage VOC, we will see later. Okay, this monitoring, when you start the drug hydroxyurea, you have to monitor CBC closely, and whenever you see the absolute neutrophil count and absolute reticulocyte count and the platelet count is less than 80,000, you have to stop the drug and you have to look for the alternative management. Okay, so that's the reason why we have to closely monitor the patient. So these are the new drugs. Okay, so that is the prevention. Prevention for part, if you see, folic acid you have to use, penicillin for the prophylactic antibiotics, and hydroxyurea has to be used as a key drug while you are preventing the complications of the SCD. Now, if the patient is presenting with the vaso-occlusive pain in ED, so whenever the patient presents to ED, we should target only five points we have to remember in mind. The first point is early recognition of the VOP. So any patient is walking in with the pain, we will be thinking some other pain. But always remember, SCD patients walking in with the pain, you think first about the VOP only, that is vaso-occlusive pain. And reduce the time to first dose analgesia. So generally, whenever the patient is coming to emergency, we will think it's a normal pain and we will ask them to wait for some time because of the crowded ER or some ACS patient is there, stroke patient is there. So we have to treat VOP patients also like stroke and MI patients only. We have to give the access to the patient as for the first treatment. So we have to reduce the time for the first dose of the analgesia. And once you give analgesia, the continuous monitoring is required, because whether the patient is improving or not also, you have to monitor. And maximize the patient safety in ED settings, and minimize the negative provider attitude. That's what. Whenever the patient comes with some normal pain, we think it is a normal pain, and we will keep the patient aside and concentrating on the other cases. So such kind of cases has to be followed and has to be addressed as early as possible. So these are the key features. Rapid evaluation in the emergency department once the patient is coming with the pain, and prompt pain relief has to be given as early as possible, and we can go with the adjuvant therapies also, that we will discuss. So rapid evaluation, so there is a timeline actually. Whenever the patient is walking in, so within 30 minutes to 60 minutes, you have to give the first analgesic dose. So if you want to give the first analgesic dose, the rapid assessment, which is nothing but the primary survey, has to be done within 30 minutes, like, ABCD, whatever we do regularly in our ED. So that has to be done in the first 30 minutes, and you have to diagnose rapid recognition of the VOP, and within 30 minutes to 60 minutes, you have to give the first dose of the analgesia. Okay, and we have to frequently reassess the patient every 30 to 60 minutes once. Okay, pain assessment, as we know, we'll be using the multiple methods to assess the pain, depending upon the severity, like depending upon the facial expressions and scoring, 1 to 10 scoring. So you just label the patient is having such kind of pain. Depending upon the severity of the pain, we are going to choose the drugs. So pain assessment has to be done along with the primary survey in ED itself. Okay, so now if we move to the pharmacological management of the pain, mainstay of treatment is opioids only, but non-opioid pharmacological agents also mentioned in the guidelines actually. This American Society of Hematology, recently they have released the 2020 guidelines, which is supporting use of the NSAIDs along with the opioids depending upon the severity of the pain. So suggests that short course of the NSAIDs, 5 to 7 days, in addition to the opioids, will give the good pain control in the patients who are presenting to the emergency. So we should think about the NSAIDs also along with the opioids. It is like evidence-based. So when you categorize the patient, like the score 1 to 4, if the mild pain is there, you can go with the paracetamol, just only paracetamol. Without opioid you can go, because the complications of opioid will be more. And if you are categorizing the patient is a moderate pain, along with the paracetamol, you go with oral or a parenteral tramadol, which is an opioid. And if the severe pain is there, paracetamol or the oral morphine, or oxycodone can be used. And depending upon the pain severity, you can use the IV drugs also for the management of the pain. Yeah. And in case of liver toxicity, as we know that paracetamol will cause more liver toxicity, and so in such kind of cases, instead of paracetamol, you can go with the ibuprofen also, and aspirin to be avoided because it may cause further Ray's syndrome. Sorry. Okay. I'm sorry. Now we move to the opioid analgesia. These are the classically we have to use the opioids only in the management of the pain. NSAIDs can be used additionally along with the opioids depending upon the pain severity. So morphine is a gold standard, and consider 0.15 mg per kg IV starting dose we have to use. And if you are speaking about the hydromorphine, which has a more potency than the morphine, if you have accessibility for the hydromorphine, you can use the hydromorphine also. The dose is 0.01 to 0.02 mg per kg. And fentanyl, which is very easily available in our EDs nowadays, so which has the 100 folds potency than they compared to the morphine. So the dose, as we know, it is a 0.5 microgram per kg. So nowadays they are using the nebulized fentanyl also, because sometimes the IV access, getting the IV access is very difficult. As we are concentrating on the first dose of analgesia, you can go with the nebulized fentanyl also with a dose of 2 to 4 microgram per kg, which will be having the similar benefit, because IV we are using 0.5 microgram per kg, but here we are using 2 to 4 microgram per kg. Inhalational fentanyl can be used. There is something called intranasal fentanyl also. So rather than using the IV also, you can use the intranasal fentanyl also, where we can keep all these intranasal fentanyl, or else nebulization of the fentanyl can be kept in triage itself for the early management of the VOP scenarios. So in this case also, you can use the intranasal fentanyl with a 1.5 microgram per kg. So if you are using IVs, it is 0.5 microgram per kg. If you are using the nebulization, 2 to 4, and if you are using intranasal, it is 1.5 microgram per kg fentanyl can be given. So opioid is a mainstay of treatment in the management of the cases. VOP cases. And ketamine. Nowadays they are telling the American Society is supporting the use of the ketamine also, alternative for the opioid, because opioid will be having the respiratory depression and the bradycardia and the toxicity features. So ketamine will be maintaining the airway reflexes also. So you can use the ketamine as an adjuvant therapy if the opiates are contraindicated in few of the cases. Okay, intranasally, again, we can use the ketamine intranasally also with the dose of 0.25 mg per kg, maximum up to 1 mg per kg. So ketamine also noted to have the antidepressive effect, so which may help in the pain transition and the management of the chronic pain also. So I'm going a little fast now, because non-pharmacological agent therapy mainly we are going to discuss about the three things. One is hydration, second one is oxygenation, third one is a blood transfusion. Hydration, as we were discussing, the dehydration is the main cause for the VOP scenarios. So hydration has to be done in the patients who are presenting with the SCD. But there is a study, this is the meta-analysis actually done on the intravenous fluid management, which fluid has to be chosen. Like, you know, patients who are having, if you are giving the fluids left and right to the patients, patient may land up in the volume overload status also, okay, because without knowing the cardiac condition. So in the conclusion, they have mentioned there is a wide variation in the practice of IVF administration in VOC patients. What they have mentioned is like, if you are not using the proper fluid in such kind of situations, there won't be control of the pain, and the patient may land up in the volume overload also. So in these conditions, when you're hydrating the patient, you have to choose the appropriate fluid with the appropriate rate only we have to choose. Generally, they are encouraging to take, rather than choosing the normal saline, they are encouraging to take hypotonic saline only we have to use. And oxygen therapy, whenever it is required only we have to use the oxygen therapy, not routinely required. And blood transfusion also in chronic cases where the patient is having ACS symptoms or the patient is having stroke symptoms, in such kind of symptoms we have to go with the blood transfusion, not routinely required. And the patients who are going for the, these are the indications for the blood transfusion: acute stroke, rapidly progressing acute chest syndrome or multi-organ failure, fat embolism, acute sickle cell hepatic crisis, and pre-operatively the hemoglobin is less than 10 and the patient is going for any of the surgeries. In that conditions, you have to use the blood transfusion. In chronic cases, if you are using the chronic blood transfusion, patient may be having the iron overload also. In such kind of cases, you can use the iron chelating agents like desferrexamine. Okay. And disposition, ED disposition is very much important. It's not like patient is having, patient had relieved with the pain and the patient is not having any other complications. In such kind of cases, you can safely discharge the patient with a close monitoring, explaining all the warning signs. But mostly if the patient is having any of the crisis symptoms and all, in those cases you can't discharge the patient. You have to keep the patient and you have to admit in ICU and you have to monitor the patient, because patient may land up in the severe complications in further. Okay, so what is like implementing an ED based vasocclusive pain management, like how we are having one chest pain clinic, how we are having one stroke clinic or stroke protocol. So every ED should have their own vasocclusive crisis pain management protocol. So once the patient comes in, walks in, immediately we have to address and primary assessment has to be done, pain scale assessment has to be done, and the initial dose of the analgesia has to be given within 30 minutes to 60 minutes, and the reassessment has to be done. So every ED should have such kind of proper protocol which was guided by the national guidelines. So this is what. So initiative focused on the reducing the time to the first dose, develop the protocol for the triage management. So apart from the IV drugs, we can use the intranasal and the nebulized drugs also, and consider incorporating alternative intravenous uses. So you can see here, the patient presents in acute pain, immediate assessment has to be done, and within 30 minutes we are going to give the first analgesia, and reassessment has to be done within 30 to 60 seconds, and we have to plan for the disposition, whether you are going to discharge the patient or admit the patient, and going to do the further evaluation. Okay. A few of the symptoms, acute chest syndrome, as we know, 2 minutes, I'll take just 2 minutes. Acute chest syndrome, as we know, once the patient got admitted, like of 1 to 3 days, the patient may develop dyspnea, and the tachycardia and the fever will be there because of the symptoms. So mainly we can manage with the antibiotics and all. Here I want to tell one thing: acute stroke. Any patient presenting with the acute stroke, the 2018 AHA guidelines are telling that you can go with the thrombolysis also in those conditions. It is recommended actually, rather than managing the SCD and the vaso-occlusive crisis, you can go with the thrombolysis also. It is actually recommended. And as I was telling, in pregnancy conditions, try to avoid hydroxyurea. And during the pregnancy planning also, as I was mentioning, whether the patient is a carrier or the patient is having a disease, or one is normal, one is abnormal. So depending upon that, the prenatal checkup has to be done, and the continuation of the pregnancy has to be, decision has to be taken by the parents. Thank you.
Any questions or any points to discuss?
Please join in front. We also want to be part of your gossip. Ma'am, you are taking a photograph there, ma'am. Cool. I'm also coming there. You come here, I'll go there.
Thank you.
Hi, Dr. Prakash, how are you? So kindly, put up your questions. How many of you have seen a patient dying with vaso-occlusive crisis? I want to hear why your patient died. What happened to your patient? Come. That's why I'm saying, please come here, kindly. Yeah.
Good morning, sir. Good afternoon, sir.
Yeah.
I'm from AIMS Bhubaneswar. I'm doing my JRship in AIMS Bhubaneswar, second year. We also received a patient. He came in pain occlusive crisis. On first day, he had only pain. Second day, slowly he developed shortness of breath, then went into acute chest syndrome, then went into MODS. Third day, he crashed.
Yes, acute, that's what. So if the patient, that's the reason why we are not going to discharge the patient if you are suspecting the VOC. So in such conditions, we have to have the close monitoring. At the same time, early start of the antibiotics, anticipating the acute chest syndrome. As you told, within 1 day, patient has developed the dyspnea and fever also. So mainly secondary infections, everything has to be controlled with the proper antibiotics, and the hydration, everything has to be given. So we can prevent it, like acute chest syndrome, whatever the patient may develop after the hospitalization after 1 to 3 days, that can be prevented actually. But the patient develops such kind of symptoms also, aggressive treatment with the antibiotic, IV hydration can prevent the any of the further complications.
Anyone else has any issues with vaso-occlusive crisis, please? Kindly come forward. Anyone has any patient who could not manage with normal analgesics? He was continuously in pain. We are from those EDs where fentanyl is not available.
Yeah. That's what I was mentioning a few of the indications. If the patient is having chronic cases or acute cases. Acute cases, what I have mentioned, acute stroke is there. If the patient is having ACS, or the patient preoperatively, you want to take the patient for the surgery. Preoperatively also you can do the. Some conditions like the chronic conditions, like patient is having acute chest syndromes recurrently, or the patient is having recurrent vaso-occlusive pain crisis, like every 3 months, every 2 months or 3 months, the patient is coming for the same complaint with the painful crisis, or the patient is having recurrent CV attacks. In such kind of conditions, you have to go with the chronic transfusions. In these chronic transfusions, you will be having the iron overload where you have to use the iron chelating agents also. So you have to divide whenever you plan for the transfusion, whether it is acute transfusion or the chronic transfusion. Few people only require the chronic transfusion if the recurrent symptoms are there. Few people require only acutely with the one time or 2 times it will get resolved. Exchange transfusion only.
Thank you. We had two wonderful talks. One for Krishna and other from our colleague. So any other questions? So I have a question for you, Dr. Krishna. You mentioned about DOACs and some trials going on whether DOACs would be helpful. So how do you see DOACs versus other anticoagulants? Because obviously DOACs is a double-edged sword. We don't really have licensed reversal agent for all DOACs. Some of them have. Number one. Number two is monitoring is a big problem in DOACs. And that's the reason probably you mentioned that there are some limitations to use. So how do you see, because you mentioned a couple of papers that have come out.
So initially in the PROACT trial 1, they compared warfarin that has been given in the normal dose versus a low dose warfarin. So they told that the INR initially we were targeting a 2.5 to 3.5. But the patient who was having a higher INR had a more chances of bleeding into their brains. So they compared with a low dose warfarin where they kept the INR of 2 to 2.5. So initial PROACT trial 1 showed that maintaining a low INR of 2 to 2.5 has the same efficacy and has a decreased tendency for the patient to develop a thromboembolism when compared to 2.5 to 3.5. So that was the outcome of PROACT trial 1. In PROACT trial 2, they wanted to compare warfarin with DOACs. But what happens was, as Sir rightly mentioned, there were no monitoring parameters to know whether there is an acute toxicity caused by DOACs. And the second thing was, when it was compared to warfarin, the study was preponderantly closed in 2022 September because they found the patient who were on DOACs had more thromboembolic states when compared to warfarin. So what they found is warfarin is better, particularly when the patient is undergoing mechanical valve thrombosis. So further studies are awaited. So it is, as of now, warfarin is the only medication that's been available for all the patients who have undergone mechanical valve thrombosis.
Thank you. Thank you so much.
Thank you, sir.
Now, a few years ago, there was a parliamentary group which came together in the UK. And the reason they came together is because there were lots of unavoidable deaths that were being reported in secondary care from patients who suffer from sickle cell disease presenting to the emergency department. And the title said, "No one is listening." How many of you have actually treated patients with sickle cell crisis? Anybody? Most of these patients, when they come to the emergency department, they look very comfortable and they're always playing on their mobile phone. But they have a sickle cell crisis, they are in extreme pain, and they have learned to manage their pain. So what most people think is, this patient looks very comfortable, he's not in pain, and they have come to the hospital because they are seeking for morphine. 99% of the patients who come with sickle cell crisis are not morphine seekers. They genuinely are in pain, and they are in so much pain that they can't manage their pain. But they're very good at managing their own pain. So when a sickle cell patient presents to the emergency department, please take them seriously. And as Dr. alluded to rightly, in the first 30 to 60 minutes, we need to treat them. And you look for complications, particularly 3 or 4. Number 1, acute chest syndrome, because if you don't treat them early, the mortality is high. Number 2, acute stroke, which you already mentioned. And 3, in the right population, priapism. So No One's Listening was a big document that was published for patients because there were a lot of avoidable deaths which could have been prevented if just people took the time to listen to them, take them seriously. And our guideline, of course, I'm not sure of other guidelines, but our guideline, the first line treatment for pain is subcutaneous morphine, because it takes time to put access, things like that. Fentanyl, as Madam said, not available in most EDs. I don't know, our ED has got, but I'm not sure about the Indian scenario. But subcutaneous morphine. But please take these patients seriously. I had one question for you, doctor. Now, hydroxyurea is more for preventive treatment.
Yes, sir.
Not for acute crisis.
No, sir.
So there is no role
Yes,
for
sir.
hydroxyurea in acute crisis.
Yes, sir.
So acute crisis is mainly managing the pain,
Yes, sir.
and then treating the symptomatology. Is it chest syndrome? Is it neurology? Is it priapism? Is it glaucoma? But if you have a patient with glaucoma, one thing, don't give a sickle cell patient acetazolamide, because it increases the risk of sickling. And also, you rightly mentioned that oxygen is not a routine treatment for patients with sickle cell crisis unless their saturations are less than 90 to 90%. That's for 2 reasons. Number 1, it causes myelosuppression, bone marrow depression. And number 2, it increases the requirements for transfusion. So you don't want to routinely give everybody oxygen. Like ACS, in the olden days, when we were students, everybody used to get the monotherapy. Morphine, oxygen, nitrates, and aspirin. But we don't routinely give oxygen now to all patients who come in with chest pain, unless, of course, they're hypoxic. So the same reason holds good. So thank you so much. My request is, please, this is a BREM session, so board reviews in emergency medicine. Please utilize the time to ask questions, to revise your knowledge, to reinforce key points, and let's make it interactive. Thank you so much. Thank you.
Thank you, sir.
Thank you, sir. Next, we move to a critical care topic, ARDS, Beyond the Books, Managing Refractory Hypoxemia. Please welcome Dr. Vasudha D. Dr. Vasudha D, MD, DNB Emergency Medicine, Assistant Professor, MS Ramaiah Medical College, Bangalore.
So good afternoon, everyone. So this is a very important topic for all ED physicians. I think, how many of you have managed ARDS? Yes, wonderful. So let us see what new things we are going to learn, and let us also fine tune our day-to-day management. So you're in your ED, it's very busy. There is a patient with PF ratio of 80 despite lung protective ventilation. You have kept high PEEP, it improves oxygenation but drops blood pressure. Recruitment maneuvers you're doing, but there are no benefits. Ventilator numbers are okay, but still the patient is deteriorating. So this is all common scenarios which we see. So are we following protocols or truly understanding the physiology is the question. So the definition of ARDS has evolved over time. So currently we all know that there is a new global definition for 2023. Currently the European Society of Intensive Care Medicine has introduced the phenotypes in ARDS. So what is a phenotype? So it is the observable trait in an individual depending on his genetic trait interacting with the environment. So broadly, all ARDS patients have a phenotype. So then they are subclassified into pathobiological endotypes depending on the etiology of ARDS, whether it was because of direct lung injury or indirect lung injury. Then again, there are biological biotypes depending on whether there is hyperinflammatory profile in the patient or hypoinflammatory. Why this is important? Because routine management, if you are going to do with lung protective ventilation and high PEEP strategy in all the patients without knowing the phenotypes, it is going to harm. Why? Because in hyperinflammatory patients, if you give low PEEP, there is increased mortality, and vice versa in hypoinflammatory patients. That is why this becomes important. So the take-home point is ARDS is not a single disease, but it is a heterogeneous syndrome. So subphenotypes influence outcomes and therapeutic responses. So coming to a case scenario, I'll quickly go through. So there is a 55-year-old male, severe community-acquired pneumonia, having worsening of breathlessness. He is tachypneic. His saturation is 92% with 50% FiO2. Blood pressure is normal. Patient is alert, cooperative. There are bilateral infiltrates. His PF ratio is 150. So the question is, what is the next best step for this patient? Should we go for high-frequency nasal oxygenation, NIV, or early intubation? So HFNO, as we all know, it gives heated, humidified oxygen. The flow rates can go up to 60 liters per minute. The FiO2 can be controlled. It also delivers a PEEP of around 5 centimeters of water and reduces anatomical dead space. So there is a landmark trial, which is Florali trial, which compared HFNO, NIV, and conventional therapy. So even though there was no mortality benefit between these three groups, there was mortality benefit at 90 days with HFNO group. There was less mortality. So who is the ideal candidate for HFNO? So patient should be hemodynamically stable, should not be in altered mental status, moderate work of breathing, and no immediate need for airway protection. So then how can you predict HFNO failure? There is something called as ROX index, where less than 3.5 suggests HFNO failure, and you can go for early intubation. So should I go for HFNO or NIV? What do the guidelines say? HFNO is usually preferred over NIV in the management of acute hypoxemic respiratory failure. So coming back to our case, the PF ratio is 150 with severe pneumonia. So what would ideal management be? HFNO with close monitoring. If oxygenation worsens, always go for early intubation and lung protective ventilation. So that is what the guidelines tell. So coming to second case, similar case, there is an ARDS patient, but now his PF ratio is 94. So that is, there is a patient with severe ARDS. So how to manage? We all know ARDS net protocol, that is lung protective ventilation. So we have been taught about this since our first years, right? So low tidal volume. So how do you set the tidal volume is based on the ideal or the predicted body weight of the patient, okay? So 4 to 6 ml per kg, maximum up to 8 ml per kg. So this is a formula. If you don't know, go back and read. So that is one thing. So tidal volume. The other thing is plateau pressure. So what is plateau pressure? It is a pressure which is left inside the lung after the tidal volume has been delivered. So what is its significance? Higher the plateau pressure means the compliance of the lung, the alveolar compliance is reduced. So what is our target in ARDS? To target a plateau pressure of less than or equal to 30 centimeters of water. So we know to avoid valve trauma, we will keep low tidal volume. So the baby lung concept. So what it was thought that in ARDS patients, because of the consolidation of fluid accumulation, the only available part of the lung which could participate in ventilation was called as the baby lung. So to prevent overdistension of this baby lung, the concept of overdistension causing ventilator-induced lung injury was brought into picture. But is it so? Because even after strictly following the ARDS net protocols, the mortalities are high. So why? Why is it happening? So for that, we should know few concepts. So first concept is lungs are not balloons. What previously they thought, a smaller balloon inflated with a large amount of air will burst, but that is not so. Instead, lungs are made up of alveoli. So you can see, so alveoli, so they are interconnected networks of alveoli. So in this video, you can see all alveoli are under equal pressure. So what is happening? The transalveolar pressure is 0. So there is no overdistension. But in ARDS, when there is a part of the alveolar or part of the lung collapsed or fluid filled. So as you can see in this video, so what is happening? 3 alveoli are moving, the one is not moving. So there is a transalveolar pressure gradient which has developed. So the open alveoli, which is present adjacent to the collapsed alveoli, will undergo rapid expansion and contraction. So rapid expansion and collapse is happening with the adjacent alveoli. So this collapsed alveoli will act as a stress multiplier for the surrounding alveoli. So this brings us to the concept 2, which is alveolar interdependence, which is the real driver of ventilator-induced lung injury. So as you can see in this normal lung, considering alveolar interconnected hexagonal network, so when there is inspiration, expiration, the difference between the alveolar size is less than 2%. So but what happens in ARDS? So during inspiration, all of the alveoli are open, but there is loss of surfactant. So during expiration, the alveoli will collapse. So you can see in this video, so the involved or the affected alveoli will recruit and de-recruit with each breath, leading to atelectotrauma, and this will create a shear pressure present on the surrounding alveoli, which will go for overdistension and have volute trauma. So previously what we thought, low tidal volume remains a standard of care. Why? Because we wanted to prevent overdistension by preventing collapse and stabilizing lung units. But now the real driver of ventilator-induced lung injury is not only because of overdistension, it is because of this atelectotrauma which is happening because of regional collapse, heterogeneity and stress amplification among the alveoli. So this is another concept. So this is concept 3, very important graph. So you can see in volume control ventilation of a patient. So this is pressure volume loop. So I just want to stress about the lower inflection point here. So what is the lower inflection point? So it is a critical opening pressure of the alveoli. Okay. So beyond this pressure is required to overcome the airway pressure and cause the alveoli to open. So what do they tell is in ARDS, what should be the ideal PEEP which you keep? It should be above the lower inflection point pressure, so that none of the alveoli will collapse during expiration. I need to set up pressure initially, the PEEP above this lower inflection point, so that even during expiration, de-recruitment of alveoli will not happen. So when de-recruitment is not happening, my atelectotrauma is not happening. So that is important. Concept 4 is driving pressure. So again, it is not only about low tidal volume or PEEP or higher PEEP. So the fourth concept is about driving pressure. So what is driving pressure? In simple words, it is the difference between the plateau pressure and the total PEEP. It is again an indirect marker of if higher driving pressure is there, the compliance of the lung is reduced, so high risk of volute trauma. So what is our target in ARDS? To maintain a driving pressure of less than or equal to 14 centimeters of water. So again, this is a new concept. So what is pendulum? So normal lungs will have fluid-like behavior. That means the pressure which is generated is distributed equally among the all parts of the lungs. But an ARDS lung will have a solid-like behavior. You can see there is a collapsed tissue. So what happens in this collapsed tissue, there is more negative pressure. For example, minus 10 centimeters of water. The rest of the lung fields have minus 5 centimeters of water. So what is the problem? So when you're delivering oxygenation and ventilation to such patients, suppose there is a normal fluid-like behavior of the lung, the volume of air which goes will get equally distributed along the entire lung because the pressures are same, right? But what happens in ARDS lung? So when the pressure is less, more negative pressure will suck in more air or less air? It's a question. So this part of the lung is collapsed. So it is more negative in pressure. Now I'm delivering the same volume of air. So which part of the lung do you think will get aerated well? So more negative the pressure, more is the air which is getting sucked in. So what is happening? My oxygenation and ventilation is getting wasted because the collapsed part of the lung is taking away the oxygenation and ventilation. So that is called as pendulift. So that is also a problem in ARDS. So why? Because there are new techniques called as electrical impedance tomography, which is coming up. There are a lot of trials going on where they are telling this can be used as a bedside tool to assess regional ventilation distribution and changes in lung aeration. So then coming to the concept 6, which is just know about it, recruitment to inflation ratio, again a bedside measure to assess the patient's recruitability so that PEEP can be adjusted accordingly. So if RI ratio is more than 0.6 to 0.7, it indicates high recruitability. That means in such patients, I can consider higher PEEP as a ventilation strategy. Mechanical power, we talked about tidal volume, driving pressure, respiratory rate, PEEP, inspiratory flow. So all of this put together, that is the total ventilator energy delivered to the lungs per minute is the mechanical power. Why this is important? Again, it is a predictor of mortality and it can be calculated bedside. So ultimately with all this, so what should we do? What to do about PEEP? So should we apply high PEEP, low PEEP, what? So it is not anymore about high PEEP, it is optimal PEEP. So dynamic adjustment of PEEP to ensure low plateau pressures aligning with overall lung protective ventilation is more important than the level of PEEP itself. So how does PEEP help? So when positive end expiratory pressure is delivered, as you can see in the picture, it will recruit the collapsed alveoli, so which will improve oxygenation. Simultaneously, it is reducing the intrapulmonary shunt and it prevents cyclical opening and closing of alveoli. That is, atelectode trauma is reduced. But everything in excess is bad. So if you give more PEEP, then alveolar overdistension will happen. So if this is happening, because of increased intrathoracic pressure, RV preload will decrease and patient can become hemodynamically compromised because of the reduced cardiac output. So we had many trials like ARDS NET, Express, LOVES and ART trial. So in the last 3 trials, they have seen whether higher PEEP is going to help in improving lung function, which is not so. So there is no mortality benefit. So currently what to follow? PEEP and FiO2, you can titrate based on targeting oxygen saturation of 88 to 95% and PaO2 of 55 to 80. So PEEP improves oxygenation, but survival depends upon avoiding overdistension. So you have to prioritize low plateau pressures and low driving pressures. So case progression, you have done lung protective ventilation, you have set an optimal PEEP, but still the PF ratio is 85 and patient is hypoxemic. So what to do next? Should I increase PEEP? Should I put him prone? Should I do recruitment maneuvers or should I go for ECMO? So how to choose the right PEEP? You can do it by lung compliance or by driving pressure technique. So what is compliance? It is change in unit volume for change in unit pressure of the lung. So tidal volume by driving pressure. What is my driving pressure? It is a difference between plateau pressure and PEEP. So you have tidal volume, plateau pressure and PEEP. So all the values are available bedside from your ventilator. So you can calculate the compliance. So what to do is you will increase PEEP by 2 centimeters of water, allow 2 minutes for equilibration and calculate the compliance. So at one point of time, the compliance will start to reduce, right? So what you should do, you should return to the point, go back to the PEEP which had the maximal compliance and set it. The other thing is choose right PEEP to maintain driving pressures of less than 14 centimeters of water. So coming to alveolar recruitment maneuvers, yes, there are a lot of trials which showed n number of recruitment maneuvers, but what is the current guidelines according to ESICM and ATS is, ESICM recommends against the use of high pressure recruitment maneuvers, more than 35 centimeters of water for more than 60 seconds is absolutely not indicated, because they are telling nowadays use more bedside available techniques like oxygen response, driving pressure change, recruitment to inflation ratio, electrical impedance tomography to decide on PEEP instead of going for recruitment maneuvers. So that leaves us with prone ventilation, neuromuscular blockade, and ECMO. So what happens in supine position? So you can see that the weight of the heart and the mediastinal structures will compress the lung, and also there is higher strain on the ventral alveoli. So there is alveolar size variability, as you can see in the first picture. What happens when I'm putting the patient on prone position? So these are the benefits of putting the patient in prone position. One thing, when I put the patient prone, there is reduction of the ventral lung compression. There is recruitment of the dorsal regions of the lung. When this happens, automatically my ventilation perfusion matching will be improved. So ventilator-induced lung injury will reduce. And also added benefit will be chest wall compliance will increase and secretion clearance also will be enhanced. So again, a landmark trial, PROSEVA trial, which included patients with moderate ARDS, PO2, FiO2 less than 150, requiring FiO2 of more than 60%. After 12 to 24 hours of optimal medical therapy, they proned the patient. So what they saw was, among the proned group and the control group, the prone patients had more ventilator-free days within 28 days. 81% were successfully extubated, and the 28-day mortality was also less in prone patients. But in ED, has anybody done proning in ED? Yes. So in ED, with those like low manpower and the chaos, it is very difficult, because ideally for proning a patient, you require 6 to 7 persons, and these are the steps in which it has to be done. That is why selection of a proper candidate for proning is important. So when to stop prone ventilation? One thing, when there is adverse events like hemodynamic instability, cardiac arrest, or worsening oxygenation after proning. The other thing, when the patient is clinically improved, that is, when in supination, at least for 4 hours, he is able to maintain a PF ratio of more than 150 with FiO2 requirement of 60%, is when you can start off thinking to stop proning. So there is again one new study going on, whether extended proning for intubated patients, that is for more than 24 hours, helps or not. So again, it is still ongoing. Evidence is observational, so still we require more studies to validate it. So what is the take-home message? Should we prone or not? So again, let us stick to the guidelines. According to ATS, American Thoracic Society, they are telling in severe ARDS patients, that is PF ratio less than 100, at least 12 hours of proning is recommended. Whereas in ESICM, if PF ratio is less than 150, requiring PEEP of more than 5 centimeters of water, despite optimal lung protective ventilation, you should prone at least for 16 hours a day. So that was about proning. Then what is the evidence for neuromuscular blockade? How does it help, neuromuscular blockade? So one thing, it will reduce a patient's work of breathing. So patient-inflicted lung injury will come down. Automatically, patient ventilator asynchrony is gone. Should we use it routinely? Again, we had 2 landmark trials, Accurus trial and ROSE trial, where Accurus trial showed benefit, that is in moderate to severe ARDS, cisatracurium infusion was better, but in ROSE trial, there was no mortality benefit. So again, the recent meta-analysis shows that there is no significant mortality benefit with neuromuscular blockade. So should we use or not? Again, even these 2 guidelines are having contrasting opinions. So ESICM recommends against use of routine neuromuscular blockade, whereas in selected group of patients like early ARDS with PaO2 or FiO2 less than 100, ATS still recommends use of neuromuscular blockade. Coming to the last thing, so ECMO. Do we have ECMO in ED? How many of you have used? So yes, it is still a tough job to start ECMO in ED, but at least you can have a multidisciplinary approach with the critical care team, and in selective group of patients, veno-venous ECMO can be used. So how does it help? It will provide total lung rest. In simple words, if the patient's native lung is not able to maintain the oxygen ventilation required, his lung will be given a rest so that the ECMO machine will take over the job of oxygenating and ventilating, especially removal of the carbon dioxide. So it is giving the lung the rest which it is required. And also, when patient is on ECMO, ultra low tidal volume, as low as 100 ml is enough to maintain the oxygen ventilation. So that is when VV ECMO comes into picture. So again, for ECMO for severe ARDS, we had two trials. One is a CESAR trial and the other is the EOLIA trial. Both of the trials were positive. In severe ARDS, they had a mortality benefit. So recent meta-analysis shows that there is 25% reduction in 90-day mortality of patients, severe ARDS patients who received ECMO. So what is the take-home message? Yes, both the guidelines recommend use of VV ECMO in severe ARDS patients, that is PF ratio of less than 80 with pH of less than 7.25 and PCO2 of more than 60. But the last para is very important. You should go for ECMO after you have used less invasive strategies like lung protective ventilation, prone positioning, neuromuscular blockade. Then only think of going for ECMO. So what you should not do, so blindly increasing the PEEP, ignoring the driving pressure, overusing of recruitment maneuvers, delaying prone ventilation, and treating ARDS as one homogeneous disease should not be done. Okay, at least these you should remember at the end of this session. So this is the ARDS net protocol. Oh, I still have 3 minutes. So to summarize, American Thoracic Society, I've taken a picture from their guidelines. So they strongly recommend use of lung protective ventilation in all ARDS patients. That is one. And prone positioning in moderate to severe ARDS. Conditional recommendation in favor of high PEEP strategies in moderate to severe ARDS. Neuromuscular blockade and VV ECMO in severe ARDS. Prolonged recruitment maneuvers for more than 60 seconds, and previously which was used, high frequency oscillatory ventilation, is no more recommended. It is harmful for the patient. This is again ESICM guidelines. You can go back and read. So to summarize, so you have a patient with ARDS, you have intubated, he's on ventilator. So go for lung protective ventilation. That is tidal volume anywhere between 4 to 6 ml per kg according to the predicted body weight. You can go up to 8 ml per kg. Then target plateau pressure of less than 30 centimeters of water and choose optimal PEEP. Also have a look at the driving pressure. Target driving pressure of less than 14 centimeters of water. Reassess the patient. If still his PF ratio is not improving and the patient is worsening, then try to find what is the optimal PEEP for this patient. But still there is no improvement and the PF ratio is falling between like 100 to 150 or less than 150, think of proning the patient and use neuromuscular blockade. But if there is PF ratio of less than 80, despite all these measures, then consider VV ECMO, discuss with the ICU and the critical care team. Don't forget reassessment of the ventilator settings, and every 24 hours the patient should be monitored. So what is not recommended is recruitment maneuvers, and HFVO is not recommended. So these are my references. ARDS management is not just changing or chasing the oxygen numbers. It is about understanding lung mechanics and ventilating the lung that actually remains. Thank you. Any questions?
Yeah, hi. Nicely presented. How do you assess clinically the phenotypes of the patient of ARDS?
Phenotypes is the external trait that is depending on all ARDS patient is a single phenotype depending on the genetic expressions
No,
and the environmental
how
factors.
do I know clinically whether this is a hyperinflammatory or a hypoinflammatory phenotypic of the ARDS patient? How can I, as a clinically, how can I know?
So
I'm
what
not- yeah.
what they are telling is depending on the etiology, whether it is direct lung injury or
Yeah.
indirect lung injury. So mostly patients having direct lung injury will be hypoinflammatory, whereas indirect lung injuries will be hyperinflammatory. If this is not enough, patient presenting with fever, sepsis, or inflammatory markers like cytokines, interleukin 1, 8, all these will be increased in hyperinflammatory.
is there something about a local lung pathology or a diffuse lung pathology? I can understand hypo and hyperinflammatory pathologies.
Local lung pathologies are usually hypoinflammatory. Diffuse lung will
Okay.
be hyperinflammatory.
So that's one way of knowing it, because all CT patients cannot go for CT scans. Are there any markers or point of care tests which can help me decide a hyperinflammatory versus a hypoinflammatory?
Procalcitonin, CRP, interleukins, and tumor necrosis factor if available. But I think procalcitonin and CRP is available everywhere. So if that is elevated, it is a clue towards hyperinflammatory phenotype.
In one of the images that you showed for the ESICM, you marked out high PEEP as a universal strategy for ARDS patient. I think that is not acceptable nowadays.
Yeah,
Yeah,
I
so
discussed
you're-
about it, that it is not high PEEP, it is optimal PEEP. But guidelines 2023,
Yeah, they
after
are
that
old.
it is
They
not
are older
updated.
guidelines.
So maybe they'll have to update
That's
it.
an older guideline. After that, only hyper and hypoinflammatory has come
Markers.
into the picture. Okay, what about proning? You said about 16 hours, 12 to 16 hours, and do it as early as possible. So, what is your strategy in your cases in the ED? If a patient of this nature comes to you, what will you do? He's come to the red zone. What is your strategy?
Ideally speaking, in my ED, we don't keep patients for so long so as to prone the patient. I think that is the same with many EDs here. So what we do is we intubate, put him on a ventilator. Maximum he'll be 4 to 6 hours with us. So lung
So
protective
you are very
ventilation
lucky
and-
you have patients only for 4 to 6 hours in the ED. We are the pathetic souls. We have patients lying here for 3 weeks in the ED. So we are pathetic people. So we probably have to do all those that you told within the ED environment itself. So we would do the proning very early. We will not even wait for a few hours if I see a patient of ARDS.
Oh.
Proning is very, very actively, it will be done. No issues. So this is one take for all the residents. If you see an ARDS patient, PF ratios are not great, below 200. The simplest thing that you can do is prone these patients. Just prone them, give them neuromuscular blockade with whatever agent you have. I'm not even selectively saying what the guidelines say, whatever you have. Give them the agent, get them onto the prone for 12 to 18 hours. The first 2 hour samples of ABG will tell you whether this is helping him or not helping him. So within the first 2 hours, so the first ABG and the second 2 hours ABG, if you're finding that the CO2s are not now going worse or the PF ratios are not changing, so that is your way of understanding this will help. But make sure that you have done a proper physiotherapy, suctioning, nebulization, fluid dynamics, lung fluid, lung lines. You have done all those things, and then you decide whether the gases are really explaining the ventilatory strategy of your patient. And don't fiddle with the ventilator. There is so much of, I see this in residents, every time they will go to a patient, they will fiddle with the ventilatory setting. Please don't touch these patients too much. You set a setting, go away, see the ABGs, see the gases, do a lung ultrasound, but don't fiddle with the ventilation issues. Somebody has said something, you thought, oh, that crappy guy put on some different ventilator, I will do something. Don't fiddle with the ventilator. Keep an inch tape, she told very rightly, know the ideal body weight. That is the most probably simple bedside tool that has to be kept for ARDS patient. Take an inch tape, measure the length, fit the formula, put the tidal volume of that patient. So these are simple tricks that you will do for your patient. A small diuretic, a few Lasix in between, you can try that. I'm not recommending it because the guidelines don't talk of that. A few intermittent Lasix, if you find lung lines, B profiles, bilaterally diffuse, you can try all these things. And even when you're proning, make sure it is not like this. For proning, it is not like this, because you see the lungs, the worst portion of the lung is this portion in the ARDS portions, okay? When he's lying supine. So when you make him prone, make sure it is like this. But don't make it too much because there will be a lot of pain in the back spine area. So even if it is prone, it is still 30 degree up, okay? Small angle has to be maintained, but ensure that the bladder points or the pressure points on the forehead, on the cheekbones, on the ankles are covered with gloves filled with fluid. with some water so that the pressure points are not there. And never keep this patient straight down because there is a tube inside. So always keep them slightly less so that you can suction them out. Otherwise, your nurse will not suction them out when he's fully down. So always keep the neck slightly like this so that you can keep suctioning. And use closed suction tubes or closed suction catheters. Don't use the regular endotracheal tubes. Have CAS systems available so that your sisters are not disconnected. Do not disconnect the tubes unless the tube is flooded with secretions. Even one momentary disconnection will just release the whatever benefit you are having. So use the CAS for this group of patients. My simple tips for you. Thank you.
Thank you.
Nice presentation. Thank you.
So, yeah, pregnant patients, so I don't deal.
Left lateral position, slight lateral, you can do that much. Only that much is allowed.
So,
Thank you very much. You have got a very nice conversational style of presenting, but you've given a lot of homework for us. Every time you say go and read, so it takes me a long time. And my memory, my attention span is much smaller than that of a goldfish. So, but that's great. And nobody is going to penalize you for finishing early. Anybody else has got any questions already? Prof has given very good pearls of wisdom.
sir is coming. Sir is coming.
She will answer the question. I have got a lot of homework to do.
It was actually a wonderful presentation because way back 1994, just when the ARDS trial came in, we were managing the first case of reported ARDS in Calicut. But then we didn't know about the low tidal volume and all those things, so we still managed. And regarding prone position, I think it is mainly for indirect ARDS. Yeah, you can try that for direct ARDS, no problem. Pulmonary pathologies, you can try, but results haven't been that good because the lungs are already damaged. So indirect ARDS, yes, we do get good results. We had a patient who had urosepsis and then landed up with ARDS. She was for hardly 25 years. And then went in for this thing and PF ratio went down to almost 80. And then we had to prone her. We developed a pneumothorax, everything, but finally she came out. But it was gratifying. But a patient with bronchopneumonia or bronchiectasis, going for an ARDS is a tough job. Yeah, proning is not going to make much of a difference. That's what we have experienced. And regarding the time, in the ED, well, we don't get patients much, I mean, more than 4 hours, and nobody's going to do I don't know, probably sir is having more time in the 3 weeks in the ED. Now, in the ICU, yes, but we do it for about 4 to 6 hours and flip back the patient. And because the trials earlier were saying 3 hours, then they said no, continue for 8 hours. Now it has become 16 hours. It's a little difficult unless we have the parameter. I mean, the physical staff to maintain this patient, because the Riles tube, the endotracheal tube, the catheter, the intercostal tube, with all these things, you have to be really, really careful when you are going to manage a prone patient. So our experience has been, so.
Discussion, and then all of us have got such patient. Anyone who would like to discuss a case of his or hers, because you must have had hypoxic patient. I often do PCV, pressure control ventilation. I want RK to Professor RK Singh.
I'll discuss one patient.
Yeah.
This SARS was going on, and we had one patient from Saudi Arabia at that time, and that was the worst of ARDS patient that we may have seen. His PF ratio was 50, and with 50, the first thing that we did was prone the guy, and we kept on proning him. So 12 hours prone, 12 hours supine, 12 hours prone, 12 hours supine. We did it for nearly 10 days. After another 15 days in the ICU, tracheostomized, he went away, discharged back to Saudi Arabia. So don't be afraid of proning. One proning fails doesn't mean the next proning will fail. I'm so much for proning, I will do it for every ARDS patient that I have. I will do a lateral 90 degrees. I'll do 90 degrees. If I can't do a full prone, I will do half like this, half like this. I'll ask my nurses to keep on changing his position every few hours to 90 degrees one, then supine, then 90 degrees like this. I'm so much for proning. The only time of investment that you will really require is during the stage of your changing over. Once you can do that, so your momentary involvement of all your staff is only for that 5, 10, 15 minutes. Rest of the times you can just wash the monitors, wash the gases, everything is done. So only at 2 times you will be more involved. Once when you start it and at the end time. Rest, 18 hours are going to be placid for you. So I would encourage all my residents to go for proning for ARDS patients. It will help you patients, okay? And there are many patients in whom it will not help, then you will know that it doesn't help, but at least do it. So in the back of your mind, you will never be having confusion, I should have done that, then something might have, okay, I have done it, it did not help, and I know it did not help. So that is where I take proning for the patient.
Thank you. And any take on pressure control ventilation, changing into PCV, will that help?
Do whichever ventilation style you are used to, do that. My ICU, I worked in intensive care for almost 18 years. So we were doing only pressures. We were very, very wary of the volume because my teacher taught me that way. So whenever it is a difficult lung, I will go with pressure modes because it stabilizes the lung. Whenever I'm doing with the normal lung pathology, something has happened, okay, volume is okay. But if you see, pulmonologists will be more tuned with volume control. But for the intensive care guys, they are more happy doing the pressure modes. Most of the time, this is what we have found working in the intensive care. But I'm happy with both. But for my teacher who taught me, pressure is number one. I will take that mode of ventilation.
Because RK is here, I'll not stop for one more question. All these students, they are all on to APRVs and all PRVCs the moment they see a refractory patient. Sorry, Vasudha, all the questions are going to him. So what is your take on all this?
When I'm not able to keep my plateau pressures below 30 and the driving pressures are going up, I may choose some of these fancy ventilation styles. But only when the P plateaus are going above 30, my driving pressures are going above 15, I am pushed to the edge, I may use some of these alternative or new alien modes that have come. Otherwise, I'm more than happy doing the stuff which the regular people will do. Okay? I have no fancy for any new modes that have come. I'm just talking of a pressure breath, I'm talking of a volume breath. That is my basic ventilation strategy for all my patients. Okay?
Thank you so much. This was, and Anand has a question and we can't.
My doubt is when we are shifting from a prone to supine or supine to prone, do we have to change the pressure limits because we are changing the patient? So in ventilator, do we have to change?
So what we'll do is we'll put the mode of ventilation in the supine, and the first time when I change over, I will keep the same modes. I don't like to fiddle with the ventilation. I really scold my students who are fiddling with the ventilation. So the same modes will go during the prone and during the supine period. No changes, absolutely. Okay?
Thank you, sir.
Excellent. Thank you so much. Yeah, please take over.
Thank you, RK sir, for those words of wisdom. And thank you, Vasudha ma'am, for that insightful and informative talk. Our next presentation explores a classic and often challenging topic in toxicology, toxic alcohols. Can we rely on the osmolar gap? And to guide us throughout this important discussion, please join us in welcoming Dr. Anusha SS.
Dr. Anusha SS, DRNB Critical Care Medicine Resident, Meenakshi Missions Hospital and Research Center, Madurai.
So, good evening, everyone. After an extensive talk followed by a detailed discussion, now we are moving on to a case. At 2 a.m. in the ED, suddenly you are getting a patient who is unconscious, with no history, no family to accompany, and with no bottles found. You are proceeding with the initial assessment. He is tachypneic, tachycardic, normotensive, and his GCS is low. Otherwise, the other systemic examination is normal. So, you are having a patient with altered mental status and you have broad differential diagnosis to consider. The labs follow. In the ABG, you find that the pH is 7.25 with a PCO2 of 28, bicarb of 12, anion gap of 24, and lactate is 1.5. You have a high anion gap, severe metabolic acidosis here, and his RFT is normal, glucose is 98, there is no hyperglycemia, serum osmolarity is 300, serum ketones are negative, urine tox screen turned out to be negative, salicylate levels, acetaminophen levels all are low, and urine analysis is also normal. CT brain is done, which is also normal. So, since we had high anion gap metabolic acidosis, we all know the broad differential diagnosis, that is the well-known cat mud piles. So, what do you want to know next? We will be interested in knowing what is the osmolar gap. So, what does it narrow down? What are the conditions in which osmolar gap will be elevated? My discussion is very small, so I will like the audience to interact. You have so much of time to talk, answer also. So, what are the conditions in which you will have elevated osmolar gap? Okay, so what is the formula for calculating serum osmolarity? I think they don't have mics, that's why they are not answering.
Actually, it is 2 into sodium plus blood glucose by 18 plus blood urea nitrate by 2.4.
Great, great. It is blood urea nitrogen by 2.8. Otherwise, it is, yes. So, with the values that we had prior, our calculated serum osmolarity is 292 for this patient. And we had a measured serum osmolarity of 300. So, what is the osmolar gap in our patient? It is 8. So, what is the normal osmolar gap? It is less than 10, right? So, here we have a normal osmolar gap, a severe high anion gap metabolic acidosis with a normal osmolar gap. So, we thought it is probably not a toxic alcohol. Okay. So, now again I want to ask, what are the causes for elevated osmolar gap?
One is, I think, diarrhea. I think secretory diarrhea is one of the causes.
So, when you will have osmolar gap? Yes. So, you have some measured osmoles and unmeasured osmoles, right? So, when you have unmeasured osmoles in your blood which is piling up, you will get an osmolar gap. And what could be these unmeasured osmoles? One of the methylene, methanol, ethylene glycol, ethanol, propylene glycol, mannitol, glycerol, all these are unmeasured osmoles which can result in osmolar gap. Okay? So, since this patient had a normal osmolar gap, it was initially thought it is probably not a toxic alcohol. So, the severe high anion gap metabolic acidosis, which was unexplained, was started to be treated with IV sodium bicarbonate infusion, fluid resuscitation, broad metabolic workup, and supportive care. But after 12 hours, acidosis worsened and the patient ended up in hemodialysis. By the time he woke up in the next day morning, there was an irreversible vision loss, blurry vision. So, what are we dealing with? Methanol poisoning. So, what were the clues here?
Hagma with normal lactates is.
Yes, so severe high anion gap metabolic acidosis, which was unexplained with the normal lactate levels and normal osmolar gap, as well as blurring of vision, because methanol toxicity is known to cause visual abnormalities. So, where did we miss? Why it was not picked up earlier? we were carried away by something. What? The normal osmolar gap, that was what we were carried away by, right? So can we really rely on the osmolar gap when the history fails us? That is the topic given to me. So for discussion in detail, what happens in the early ingestion? The early ingestion, that is when the patient is taking the alcohol, that is the parent alcohol, either methanol or ethylene glycol, the initial blood levels are mostly because of the parent alcohols only. Okay, the metabolism has not started yet. So these parent alcohols are osmotically active. So they are the ones which are responsible for the osmolar gap. So in the early phase of ingestion, your osmolar gap is going to be high, but the anion gap will be normal. There will be minimal or no acidosis. Why? Because it is not getting metabolized into acids yet. Okay, so in the early phase, remember, osmolar gap is high, whereas anion gap is going to be normal. Next, slowly metabolism is going to begin, and the levels of parent alcohol will come down, and the acids will start rising up. Okay, as we all know, the alcohol will be metabolized by alcohol dehydrogenase to aldehyde, and then the aldehyde will be metabolized by aldehyde dehydrogenase to acids, right? So the osmolar gap will start falling, anion gap will start rising, and the acidosis is developing. In the late presentation, when the patient presents to you very late, the parent alcohol levels are really low, that the osmolar gap might be normal, and here the acids have piled up. There is accumulation of either formic acid in case of methanol toxicity, or glycolic acid and oxalic acid in case of ethylene glycol toxicity, and you are going to have a very high anion gap with a severe high anion gap metabolic acidosis. So can you exclude toxic alcohol with a normal anion gap? If you are seeing an ABG with a normal anion gap, can you tell that the patient didn't have a toxic alcohol? No. Can you exclude a toxic alcohol ingestion by means of a normal osmolar gap? No. So it is highly dependent on when the patient is presenting to you. So a falling osmolar gap with a rising anion gap is the natural history of a toxic alcohol poisoning. So the osmolar gap, is it useful or misleading? It is a time-dependent marker. It can be high in the early phase, whereas it can be normal in the late presentation. And it has got a wide normal range. The normal osmolar gap, it varies from somewhere between -10 to +15 milliosmoles per kg. Okay, actually that is -15 to 10 milliosmoles per kg. So if a patient, say a patient was having a baseline level of -15 milliosmoles, okay, and he had consumed methanol, and his osmolarity level raised by 20, what will be his measured osmoles now? -10, -15 to +20 also, it will be only +5. In that case, you will think it is a normal osmolar gap, whereas it has actually elevated. So because of the wide normal range, you might miss the toxic detection. And then lab variability is also there. That is, measured osmolality varies between lab analyzers. And ethanol, propylene glycol, mannitol, IV contrast, and some other interfering substances, they can cause false positive results of increased osmolar gap. So a normal osmolar gap as well as a normal anion gap does not exclude toxic alcohol poisoning. So when to treat despite a normal osmolar gap? Whenever you have a patient with an unexplained high anion gap metabolic acidosis with no obvious cause, suspicious exposure, and with the presence of clinical clues, you can think of toxic alcohols. And what you have to remember is, you have to treat before you measure the serum concentration levels. You always start treating the patient empirically. So what is the definitive diagnostic measure? You have to measure the serum methanol levels or ethylene glycol levels, which might not be available in all the places, right? So you can treat before you measure the serum levels. So when will you suspect toxic alcohol exposure? You should know what are the common sources, right? So methanol can be found in windshield washer fluid, industrial solvents, illicit alcohol, fuel additives, paint removers, embalming fluid. Similarly, ethylene glycol can be seen in antifreeze, radiator coolants, hydraulic brake fluids, de-icing solutions, foam stabilizers, and many of the industrial solvents. So coming on to the methanol toxicity, next what we have to know is, what are the clinical features and what is the mechanism of toxicity, right? So what happens, the methanol, it is So methanol, it is being metabolized by alcohol dehydrogenase and it gets converted to formaldehyde. And then by aldehyde dehydrogenase to formic acid. Here what you have to know is, when this conversion is happening, there is another conversion which is also happening simultaneously, right? That is NAD plus is getting converted to NADH. So at the end result, you will have an increased NADH NAD plus ratio. Okay. So what happens when there is an increased NADH NAD plus ratio? There is increased conversion of pyruvate to lactate, which is also occurring simultaneously. So these patients are going to have lactic acidosis as well. Okay. Here, this formic acid, what happens to the formic acid? What will it do? It will go and bind to the iron and it will cause inhibition of mitochondrial cytochrome oxidase. So it is going to inhibit the cellular respiration. Okay. This formic acid, in the presence of tetrahydrofolate, it can get converted to CO2 and water. Okay, just remember this because that will help us with the management part. Okay. So whenever there is a decreasing pH, when the acidosis is increasing, it will promote the formic acid diffusion across the cell membranes, especially across the CNS membranes, and the toxicity is going to increase. And it potentiates the inhibition of cytochrome oxidase by the formic acid as well. So there is a concept of circulus hypoxicus. Here you can see that this formic acid, it causes inhibition of mitochondrial respiration, resulting in tissue hypoxia. And this tissue hypoxia will result in lactic acid production, and there is going to be increased formic acid toxicity, which will again result in toxic tissue hypoxia and again lactic acid production. This will cause circulatory failure, which will again worsen the tissue hypoxia, and this is going to be the vicious cycle, that is the circulus hypoxicus. So what are the organ systems which can be involved in methanol toxicity? In the early phase, the patient might present you with GI symptoms like vomiting, nausea, loss of appetite, and you can find patients with acute pancreatitis as well. And due to metabolic acidosis, there will be a compensatory tachypnea, hyperventilation, shortness of breath. Patient may present with chest pain also. The organ systems particularly involved are, one, the optic system, and the other is CNS. Okay. So in the optic system, you will have acute vision changes, impaired vision, snowstorm vision, that is blurry vision will be there. In the CNS, the patients can have headache, dizziness, altered mental status, slurring of speech, nystagmus, ataxia, confusion, and in severe cases, they can present you with seizures and coma. So the specific target tissues are optic disc of the retina, retrolaminar optic nerve, basal ganglia, and subcortical white matter. Coming on to the ethylene glycol toxicity, here ethylene glycol, it is being metabolized by alcohol dehydrogenase to glycoldehyde, and then by aldehyde dehydrogenase to glycolic acid, and then it is being metabolized to glyoxylic acid and further to oxalic acid. Here, the main toxic metabolites are glycolic acid and oxalic acid. Here also we can see that there is going to be an increased NADH NAD plus ratio, which is resulting in lactate production. And the glyoxylic acid, it has got two more metabolites, that is alpha hydroxy beta keto adipate, and here thiamine is the cofactor. And the other one is the conversion to glycine, where pyridoxine is going to be the cofactor. Okay. So whenever there is accumulation of glycolic acid, it is going to cause profound metabolic acidosis, and this increased NADH NAD plus ratio resulting in lactic acidosis. And the other mechanism of toxicity is going to be the precipitation of calcium oxalate crystals in the proximal renal tubules, which can result in acute tubular necrosis and acute renal failure. This calcium oxalate, it can also get deposited in the brain, resulting in cerebral edema, intestinal mucosa, which can result in gastroparesis, lungs, resulting in an ARDS picture, heart, causing myocarditis, spleen, which can result in profound anemia. And due to the chelation of calcium with the oxalate, there will be systemic hypocalcemia. So the clinical clues will be systemic hypocalcemia, acute renal failure with the unexplained high ion gap metabolic acidosis, and in urine you might find the calcium oxalate crystals. So coming on to the clinical features, the ethylene glycol toxicity is mainly described in three different stages. The early stage or the first stage is the acute neurologic stage, which is from the 30 minutes to 12 hours after ingestion. The symptoms vary from inebriation, euphoria, CNS depression, coma, hypotonia, seizures, nystagmus, ataxia, myoclonic jerks, or cerebral edema. The next stage is the cardiopulmonary stage, which is the most deadly stage, that is from 12 to 24 hours, in which the patient can have tachycardia, severe metabolic acidosis, compensatory tachypnea, hypoxia with pulmonary edema, ARDS, multi-organ failure with circulatory collapse. In this phase, the patient might succumb to death as well. And the third stage is renal stage, which is from 24 to 72 hours, in which the patient can end up in acute renal failure, flank pain, costovertebral angle tenderness, hematuria, proteinuria, anuria, oliguria, or non-oliguric patients you might find. So you have this calcium oxalate crystalluria, that is, it could be either monohydrate or dihydrate. So with these clinical clues, we might want to treat the patient at the earliest, right? So how will you be treating? So any toxicology topic starts with decontamination, right? So what is the role for decontamination? Is there any role for gastric decontamination in this toxic alcohols? Okay, so the next question is how rapidly does it get absorbed from the GI tract? Any guesses? If the patient presents to you with within this much time, I will do the gastric decontamination. So it is hardly 5 minutes that it is going to get rapidly absorbed. Okay, so there is no role for gastric lavage. It is not recommended. If at all there is a large volume exposure, then you can do a gastric suctioning alone. The next step of management is the correction of acidosis. We have already discussed that acidosis is going to worsen the toxicity by means of both increasing the inhibition of cytochrome oxidase as well as it is going to increase the diffusion across cell membranes, right? So definitely we want to correct the acidosis. And in case of ethylene glycol toxicity, the sodium bicarbonate administration, it increases the urinary excretion of ethylene glycol as well as it can delay the calcium oxalate induced acute renal failure. So if pH is less than 7.3, you will give IV sodium bicarbonate to normalize the pH, that is 7.35 to 7.45. So sodium bicarbonate bolus of 1 to 2 milliequivalents per kg will be given, followed by an infusion, that is 150 milliequivalents per liter of sodium bicarbonate in 5% dextrose at 1.5 to 2 times the maintenance fluid rate. Until normalization of serum pH, that is 7.35 to 7.45, you are going to continue the bicarbonate infusion. And meantime, you have to monitor if the patient is developing any hypernatremia or hypokalemia, and this should not differ any definitive elimination of the parent alcohol or its toxic metabolites. It is just a supportive measure. Definitely you should go with the elimination procedures as well. The next is metabolic blockade, that is inhibition of production of toxic metabolites. As we already know, the methanol and ethylene glycol are less toxic than its metabolites. So we want to inhibit the conversion to toxic metabolites. So where we want to act is at the alcohol dehydrogenase levels, right? So formimazole or ethanol, it causes inhibition of the alcohol dehydrogenase. So the half-life of the parent alcohol will be increased in these cases when you use metabolic blockade. So what is the criteria for initiation of metabolic blockade? It is documented plasma methanol or ethylene glycol concentration of more than 20 milligrams per deciliter, or when there is a history of ingestion of methanol or ethylene glycol and an osmolar gap is more than 10 milliosmoles per liter, or if there is a strong clinical suspicion of ingestion, then at least 2 of the following, that is arterial pH less than 7.3, serum bicarb less than 20, osmolar gap more than 10, and urinary oxalate crystals present in case of ethylene glycol poisoning. If any 2 of these are there, you can go for metabolic blockade. So we had 2 options. One is formimazole and the other is ethanol. Which is preferred? Formimazole is preferred. Why? Because it has got a safety profile, there is an ease of administration, and the adverse drug event rate is 7-fold lesser in the formimazole group compared to the ethanol group. So what is the only contraindication? Severe allergic reaction, and the side effects are mild, including headache, nausea, dizziness, and phlebitis is known to occur. In case of rapid infusion, the patient might go for hypotension and bradycardia. So what is the dosing? It is loading dose of 15 mg per kg IV, followed by maintenance, that is 10 mg per kg IV every 12 hours for the initial 48 hours. After 48 hours, we have to increase the dose of fomepizole because it itself will induce its metabolism through the cytochrome P450 enzymes. So you are increasing the dose to 15 mg per kg IV every 12 hours. If the patient is on hemodialysis, the dose is going to be the same, but the frequency is going to increase. That is 15 mg per kg IV every 4 hours you have to give during hemodialysis. The next is ethanol therapy. The affinity of alcohol dehydrogenase for ethanol, it is almost 10 times greater than that for methanol. But what are the problems? It has got a complex dosing, and when we use ethanol therapy, we have to measure the serum ethanol concentration every 1 to 2 hours, and we have to make sure that the ethanol concentration is maintained between 100 to 150 milligrams per deciliter. Then only it is going to be effective. What are the side effects? Worsening CNS and respiratory depression, hypotension, vomiting, phlebitis. You might need a central line to infuse IV ethanol, and hypoglycemia in case of children and malnourished. IV ethanol dosing, it is 10 ml per kg of 10% IV ethanol, and at the rate of 100 mg per kg per hour. And you have to keep the ethanol level between 100 to 150 milligrams per deciliter. But what is easily available is oral ethanol. So how can you give oral ethanol? It is with a loading dose, that is 80 proof liquor of 1.5 to 2 ml per kg, followed by maintenance dose of 0.2 to 0.5 ml per kg per hour. 1 ml of ethanol is almost equal to 0.8 grams. So 30 ml, that is one shot of 80 proof liquor, it contains around 9 to 10 grams of ethanol. So loading dose is 3 or 4 30 ml shots, and maintenance is going to be 1 or 2 30 ml shots. If someone is wondering what is 80 proof liquor, what is this grams, all those things, 80 proof liquor is nothing but 40% alcohol by volume. All your vodka, whiskey, rum, gin, tequila, all this fall under this 80 proof liquor, and 30 ml of this is 40% of alcohol. So that is 12 ml of ethanol, and 1 ml of ethanol equals 0.8 grams. So 12 ml will equal almost 9.5 grams of ethanol. The next step is hemodialysis. So it helps by removing the parent alcohol and its metabolites. It helps in correcting the acidosis as well as aiding in fluid management and cardiovascular stabilization. So what are the indications for hemodialysis? If there is a refractory metabolic acidosis with a pH of less than 7.3 and renal failure, vision abnormalities in case of methanol exposure, when there are electrolyte imbalances which are unresponsive to conventional therapy like hyperkalemia, hemodynamic instability, methanol or ethylene glycol concentration, and it is more than 50 milligrams per deciliter, you can go for hemodialysis. Which mode is preferred? Intermittent hemodialysis is preferred compared to the CRRT. So what are the endpoints for discontinuing either this hemodialysis or ADH inhibition? One is the acid-base status should become normal. There should be resolution of the metabolic acidosis. And the other is the toxic alcohol concentration should be less than 20 milligram per deciliter. The serum levels should be measured. So is there any role for vitamins in toxic alcohol ingestion? The first, in the methanol toxicity, we were discussing on the conversion by tetrahydrofolate synthase to carbon dioxide and water. So the folic acid or the activated form of folic acid, that is folinic acid, it aids in formic acid elimination by the formation of carbon dioxide and water. So you can give 1 mg per kg of either folinic acid. If it is not available, you can use folic acid every 4 to 6 hours IV, and it should be continued until the toxicity is resolved. In case of ethylene glycol poisoning, you can give pyridoxine 50 to 100 mg IV 6th hourly for 24 to 48 hours, thiamine 100 mg IV 6th hourly for 24 to 48 hours, and magnesium sulfate can be given as a single dose, that is 2 grams. So this is to sum up. Fomepizole as well as ethanol acts at the level of alcohol dehydrogenase to prevent the formation of further toxic metabolites. Your folate supplementation acts in the conversion of formic acid to carbon dioxide and water, and hemodialysis, it acts in the elimination of both the parent alcohol, that is methanol, as well as its metabolites, that is formic acid, which is toxic. In the ethylene glycol toxicity, ethanol or fomepizole acts as the alcohol dehydrogenase and prevents the conversion of ethylene glycol to glycolaldehyde. And pyridoxine and thiamine, it helps in conversion of glyoxylic acid to the inactive metabolites. As well as your hemodialysis, it is going to help in eliminating ethylene glycol as well as the other toxic metabolites. So these are the questions for the residents here. So what is lactate gap? So we were talking extensively about anion gap and osmolar gap. I wanted to know if there is some term called lactate gap. And if so, where is it seen? So you can answer any of the 5 questions. Isopropyl alcohol is another toxic alcohol. So what is the classic finding in isopropyl alcohol? With respect to the osmolar gap and the acidosis part. Okay, let me tell. So lactate gap is seen in ethylene glycol poisoning. Okay, why and how? Shall I give homework like Dr. Vasudha or? Okay, so ethylene glycol, the glycolic acid, as we know, it has a structure which is similar to lactate. So the point of care analysis might give it as an increased lactate level when there is a lactate oxidase system. Whereas the lab analyzers, lactate dehydrogenase system is used, the lactate levels will be normal. So you'll find that the point of care analysis, the lactate level is high, and lab analysis, lactate levels are normal. So there will be a lactate gap which is seen in ethylene glycol toxicity. What is facial auditory nerve oxalosis? At least from the term oxalosis, you will know which toxicity it will be there in. Ethylene glycol poisoning, right? So the ethylene glycol poisoning, there will be delayed neurologic syndrome, which is called the facial auditory nerve oxalosis, in which cranial nerves 7 and 8 are involved, which will be seen from around 5 to 20 days after ingestion. And the classic finding in isopropyl alcohol, here there will be no acidosis, only ketosis, okay, and a elevated osmolar gap, okay. So isopropyl alcohol ingestion with profound shock, what could be the causes? So what will be the major problem here? One is the hemorrhagic gastritis. Patient may present to you with profound GI hemorrhage, which could be a cause for shock. Otherwise, there will be profound vasodilation. Cardiac inotropic effects will be low. All these could be the cause for shock in case of isopropyl alcohol ingestion. Metabolite of diethylene glycol is ethylene glycol. True or false? At least true or false you can tell. It is false. It is 2-hydroxy ethoxy acetic acid, that is the metabolite of diethylene glycol. So the take-home message, osmolar gap, it reflects the parent alcohol, not the metabolites. Late presenters, they may have a normal osmolar gap. Unexplained hagma, always think of toxic alcohols. Treat early, you can confirm it later. Thank you.
Thank you very much. I think that was quite a comprehensive presentation. So if you travel to London, and most Londoners commute by what we call the underground, and every time there's a message in the underground saying, mind the gap. Mind the gap between the train and the platform edge. So you have to mind the gap in toxic alcohols. You have to mind the osmolar gap, which could be normal, because it decreases with time, and mind the gap with acidosis. I think you've covered quite extensively, and isopropyl alcohol is very common in the US. People who have this alcohol rubbing gels, they keep ingesting. Apart from hemorrhagic gastritis, if you have a patient who comes in with profound inebriation, because normally with ethanol toxicity, you will expect some zero-order kinetics and fixed amount is being given out or metabolized. And if these patients have profound inebriation and for a very long time they are intoxicated and they are not sobering up as normal. So visual clues in toxic alcohol poisoning, which most clinicians ignore. I know anesthetists and critical care physicians don't ignore, and that's respiratory rate. So you have tachypnea because these patients have some sort of metabolic acidosis and they want to blow off the CO2. So if somebody is tachypnic, if they have visual symptoms, if they have seizures sometimes which are delayed, you have to be careful because these are the visual clues. And inebriation, people who are not, if you assume somebody's reduced level of consciousness is because they are intoxicated, then you'll surely miss something. You'll miss a head injury, you'll miss toxic alcohols, and you'll miss other pathology. So never assume that a patient's reduced level of consciousness is because they are drunk. That is the last thing. So thank you very much, unless somebody has got any other questions. Yes, please.
I just wanted to know, because hostel life, a lot of young students, availability of nail polish remover in girls' hostel. I recently encountered in my daughter's college also. So how is it different or similar to other toxic alcohols?
So it is acetone, ma'am. Usually the isopropyl alcohols, metabolite is acetone.
Okay, yeah. So it
So
won't
it is just
be
ketosis that will cause, otherwise
nothing much.
nothing much.
Thank you so much. Means you need, it would be like a supportive management. would
Supportive
you?
management.
Thank you. That's it.
Today's day and age, because now you have nail polish with every n number of colors, isn't it? So people can go in for that. It's easily available. And even children sometimes easily available, because if the parents are using and they leave it, they find it colorful bottles and then take. Thankfully, it's only supportive treatment. So thank you very much once again.
Thank you.
Thank you, sir and ma'am. Our next talk focuses on the diagnostic challenge of acute mesenteric ischemia, a condition where early recognition can make a life-saving difference. To guide us through its clinical aspects, please join me in welcoming Dr. Hariprasad.
Dr. Hariprasad, MD, DNBEM, MRCEM, FAEME, Senior Resident Emergency Medicine, AIMS, Delhi.
Yeah, it's a recent one from FIFA, Football Association. Yeah. So, yeah, we have got a big introduction about me. Myself, a senior resident from AIMS, Delhi. So we have got a very underdiagnosed condition, which we usually see in ED, but we underdiagnosed it as something else. And once the pain is settled, we will refer out the patient mostly. So we'll walk through this. So in this condition, which is the underdiagnosed, that is mesenteric ischemia, whether we can diagnose it with CT angio, is it foolproof, or what is the limitation of CT angio? And if CT angio is normal, then what next step what we can do? Is there any clinical suspicion we can do? Is there any normal findings in the imaging, which are subtle image findings that we can look in the CT to diagnose such things? And a diagnostic approach in equivocal cases. We'll start with a normal case and we'll slowly complicate things, and when to involve surgery. So these 5 will be the learning points. So first of all, so this is this case is presenting to Mr. Binod, will be the doctor. So is the hypothetic doctor. He has got a patient who has severe abdominal pain for 6 hours. He has history of atrial fibrillation, but that is not on any anticoagulants. On physical examination, it is soft abdomen. So Dr. Binod has proceeded with CT angio that came to be normal. So he thought, okay, there is no vascular occlusion. We can discharge the patient as the pain is also a bit settled as diagnosis as gastroenteritis. But after 12 hours, toward the end of his shift, patient came broad dead. And the autopsy finding was extensive small bowel infarction due to mesenteric ischemia. So what must have been done to save this elderly male? So this is an underdiagnosed condition where mortality is very high, 60 to 80% if not diagnosed. It accounts for just 1 in 1,000 cases of our ED visits, and mostly elderly patient is affected. And if we miss the case, mortality is very high. And like time is brain, time is heart, time is limb. This time is bowel in this case. We will discuss about the timings. So why mortality occurs and why it is difficult to diagnose? The only presenting symptoms may be sudden severe abdominal pain which is not responding to analgesics. And the initial pain may be due to just the mucosal involvement. Later it progressed to submucosa and muscularis. And once the muscularis layer is involved, patient will have peritonitis signs. Then we will think of, okay, this is something, is surgical abdomen. But when you diagnose such a case at the time of peritonitis, it's already the delayed presentation now. And patient's mortality rate is around 90 to 95% in this case now. So we should know a little bit about the vascular battlefield. That is, the superior mesenteric artery is supplies from duodenum till splenic flexure. Inferior mesenteric artery, the labeling is wrong. It is bit up. And it supplies till the upper rectum. The SMA is most commonly involved because of the large diameter and low takeoff angle. And there are two ischemic points. One is Griffith's point, where there is middle colic and left colic artery meet, that we have studied in our first year anatomy classes. And that is marginal artery of Drummond will be there. And there is another one called Sadek's point towards the rectum, where the last sigmoidal artery meets with superior rectal artery. These are the four things to be noted. So when sudden severe abdominal pain comes, we will diagnose as vascular cause, intestinal, inflammatory, perforation, infectious, or other causes like pneumonia, decay, renal colic, etc. But we should keep mesenteric ischemia as one of the DDs in elderly patients with abdominal pain and some comorbidities. So what are the types of acute mesenteric ischemia? 4 types. First one is embolic. This is the most common because many of them may be having atrial fibrillation which is undiagnosed, or sometimes there can be a recent MI, endocarditis. Such subset patients present with sudden abdominal pain with vomiting. In the second subset, that is thrombotic arterial mesenteric ischemia, it will be in a cardiovascular patient where there is a diffuse atherosclerosis due to plaque rupture. They present with acute and chronic postprandial pain, and because of postprandial pain, he will eat less. There will be weight loss also. Another one is venous. Venous is present in hypercoagulable states and acute pancreatitis. There can be thrombosis in the superior mesenteric vein. It is the subacute involvement evolving over days. And the most missed one is non-occlusive mesenteric ischemia, where there is momentary vasospasm in some cases. Sometimes there will be, due to hypoperfusion, there will be severe vasoconstriction like shock, cardiac failure, high dose of vasopressor that we usually use in hypertensive patients. In those sets of patients, there can be progressive pain to begin with, and sometimes there will be abdominal distension. So acute arterial embolic, the artery involved is SMA. In case of thrombotic, any of the arteries can be involved, and mesenteric venous, SMA and SMV can be involved, NOMI can involve anything. So how to diagnose? Any imaging? X-ray will be normal in most cases. Ultrasound again will be normal. Oral contrast, not advised because patient will present with signs of obstruction. Biphasic CT is advised, and unenhanced phase will screen the vascular calcification and hyperetenating intramural hemorrhage. And later in the arterial and venous phase, we can find whether there is any thrombus, bowel wall enhancement, and look other organs for any concurrent emboli. So why CT angio is normal? Any ideas? So it is normal because sometimes it is early ischemia where there will be no bowel changes. Sometimes it will be non-obstructive where there will be no vessel change. Sometimes it can be intermittent spasm or low flow states like shock, or it may be before the golden window of CT. So normal CT angio is never equivalent to ruling out acute mesenteric ischemia because the sensitivity of CT angio in this case is less than 64%. So in this case, only thing which can help you is your clinical judgment. So look for red flags like pain out of proportion to physical exam that we have discussed, high risk factors. Just to add, cocaine use and other hypotensive states should also be considered in this high risk factors. Mostly males are involved because female have estrogen protection in before menopause, but post menopause they are equally involved. And other risk factors are intra-abdominal malignancy and any recent history of embolic involvement. So classical triad just present in just 50% cases, abdominal pain with rapid emptying symptoms like diarrhea, vomiting, and history of cardiac disease. So this is the timeline of presentation. First 6 hours, there will be just severe pain with normal exam or minimal exam findings. Next 6 to 12 hours, there will be bloody diarrhea. That will be fresh bleeding to start with worsening pain. From fresh bleed, it will change to melena, black tarry stools. And late stage, there will be peritoneal signs. That's almost serosa is involved. So it's point of no return. The mortality is very high. So window is till 6 hours or 3 to 6 hours. It's a kind of intestinal stroke. You can also say like this. So when to suspect is when the clinical exam mismatch the patient. It will be soft abdomen to match with, and later it will become rigid when the cirrhosis is involved. Any lab test that can help? TLC is not specifically elevated. D-dimer may be elevated. And if D-dimer is normal, it rules out intestinal obstruction. Lactic acidosis, which is unexplained, may be one of the presentations of this NDT. So these are some of the early CT findings. The first one is paper thin wall because of the muscularis propria and submucosa has nerve plexus. When that is involved, there will be loss of muscle tone. So the bowel will be extremely dilated, leading to paper thin wall. The next one is target sign. Sometimes as a DD of induced assumption is seen in vascular venous type, whether the white followed by this isoindense area is due to edema, which is occurring from the vascular leak. And the last one is pale ischemia and shock bowel. Pale ischemia is due to uh, arterial occlusive causes, and shock bowel, there will be hyperattenuated bowel, which is seen in NOMI, non-occlusive mesenteric ischemia. And late cases, there can be air outside the intestine, and sometimes isolated bowel can also be seen. Pneumatosis intestinalis and portal vein gas can be present. So a word about non-obstructive mesenteric ischemia. So the patient will be having shock or hypotension. So what you will give? Will give fluids. If not responding, you will give vasopressors, and vasopressor will cause plantar vasoconstriction leading to bowel necrosis in this case. The only diagnostic thing we can do is one, shock bowel if we can find. Other is, the first one will be the normal SMA diameter when you scan first. But after some time, when you repeat the scan, there will be decrease in the size of SMA. More than 2 mm decrease is again suggestive of non-obstructive mesenteric ischemia. So 6 hours we have discussed, and every hourly mortality increased by 10%. So high risk suspicion should be there. Order CT angio and labs. If negative and high suspicion, look for clinical examination. Don't discharge the patient. Do serial examination, like if there is RT in situ, look for blood inside the artery in the Ryle's tube. If there is Foley's catheter, look for blood, because there can be embolic involvement leading to microscopic hematuria, later macroscopic hematuria. Look for stool output. Initially there can be normal stool, later fresh blood, then black tarry stool. So look for all the orifices, serial abdominal girth assessment, serial lactate, and repeat the scan after 6 hours, and early surgery consultation can be done. This is just the algorithm that we have just discussed. So it's a female patient, like Dr. Binod has managed, has already died because he has discharged. But the second chap, 65-year-old male, who has CABG history, CT angio was normal, but he did not discharge the patient. He got a repeat scan where SMA occlusion was found to be visible, and emergency surgery was involved, and the patient was saved. So sometimes subtle signs are focal bowel thinning, asymmetrical bowel enhancement, some free fluid present, mesenteric vein haziness, decreased bowel wall enhancement. This may be some of the subtle CT findings that will be present before 6 hours. Surgery is involved when there is any peritoneal signs, CT findings, refractory pain, if there is rising or lactate despite resuscitation. Management will be giving IV fluids, antibiotics, NG decompression, pain control, avoid vasopressors. Fluid is 20 to 30 ml per kg of bolus, followed by 150 to 200 ml per hour, because this is again third space losing. We can repeat bolus if the patient is hypotensive, RL is preferred. Vasopressors, double-edged sword. So use lowest dose. We can use norepinephrine or vasopressin as adjunct, but avoid epinephrine, dobutamine, dopamine, and phenylephrine. Antibiotics, start with empirical ones, and if shock, go for meropenem. Whether any role for thrombolysis, systemic thrombolysis is controversial. There is no guideline recommendation. In some cases, they have used 5 mg of alteplase followed by infusion. Catheter-directed thrombolysis is advised, where the indications will be arterial occlusions without any signs of peritonitis and without bowel occlusion, bowel infarction. In case of venous cases, we will start with anticoagulation for 24 to 48 hours. If that is failed, then catheter-related thrombolysis is tried. And the agent used is alteplase. And the right side shows that thrombolysis and anticoagulation summary. In non-obstructive case, no thrombolysis or anticoagulation is done. Anticoagulation, it is done concurrently during catheter-directed thrombolysis and as first line in venous thrombosis. And we should adjust the dose using Rashke nomogram. In case of NOMI, conservative treatment will cause 96% mortality. And if we use papaverine intraarterially or PGE1 infusion, there is 65% cases of survival in NOMI. So, pitfalls to avoid is false reassurance from normal CT, delaying the surgery consultation, attributing pain to benign causes like gastroenteritis, missing NOMI in ICU patients on vasopressors, discharging high-risk patients early. Keep them if you have clinical suspicion and repeat the clinical examination. So Thymus bowel we have already discussed. So just before finishing, we can just add some more things so that we can complicate. So if the patient presents with sudden onset severe abdominal pain with and patient will have melena, hematuria also. So in this case, will you do thrombolysis, anticoagulation, or you will do surgery consultation first? What's your opinion? Mesenteric ischemia case, I said there can be sometimes presentation as melena, hematuria also. So should we give anticoagulant? Those who will give, please raise the hands. Those who don't give, please raise the hands. Okay. So why not giving?
As you said before, sir, like most of the cases don't sign any early signs, no guarding, no rigidity, only abdominal pain. And once we suspect, like we received 4 or 5 cases in the last 1 year. So all the cases did not have any guarding or rigidity initially, but we were very specific. They have some very vague signs, but the patient had underlying conditions. So we took for a triple phase instead of biphasic. We do a triple phase CT in our setup. So when we found the patient was having ischemia, when they took it to the theater, so whatever the CT finding that was given, it was much worse when they explored it. So we started avoiding giving heparin because intraoperative bleeding, to prevent intraoperative bleeding. That's what I was advised by my surgeon. So
Okay. Yeah, surgeon's point of view was also correct, but there is also less guidelines on this topic. But the other point of view, where the World Society of Emergency Surgery is saying is, this is due to venous thrombosis or occlusion, that is causing mucosal infarction, that is causing this initial hematochezia, and later when the bowel wall is involved, muscularis is involved, there will be melena. So the cause is due to some thrombotic cause. So in such cases, they say it is no harm in giving anticoagulants. But if the patient is severely bleeding, then do hemodynamic resuscitation and side by side just start heparin infusion. They are not advising LMWH or any other agent, and we have to manage according to Rashke nomogram. That's the literature says. So the take-home message is the clinical gestalt always wins in this case, and it is a surgical emergency which is underdiagnosed. If we diagnose, we can save the initial case. I have recently seen one young patient who has who was 23-year-old only, and he presented with initially hematochezia and later it was melena. When the scan was done, there was frank mesenteric ischemia. Was taken for OT. There was extensive bowel gangrene. They have done decompressive damage control surgery and posted for revascularization once patient is hemodynamically stable, but unfortunately he succumbed to death. So it is very high mortality condition. So when in doubt, observe and reassess. That's the only thing we can do in this case. So this is the summary that we have already discussed. So these are the references. Thank you for your patient listening. Any questions?
Thank you very much. I think that was a good comprehensive presentation on mesenteric ischemia. So the top key tips are think about it in any elderly patient with abdominal pain. There are lots of third space losses, so you must give good fluids, IV fluids. Anticoagulation you've already discussed. CT you've already discussed. And of course, avoid pressors. If you have to use pressors, use the ones which have least vasoconstrictive effect on the splanchnic circulation. We're not giving epinephrine. You might want to use something like dobutamine or milrinone, which have less vasoconstrictive effects. So they still have vasoconstriction on splanchnic circulation, but you have to keep that in mind. You don't want to give epinephrine or phenylephrine, things like that. So thank you very much, Hari. That was a good presentation, and you've covered a lot of important clinical points, which is very important, because this is a condition which is more often missed. And the problem is, it's not with the emergency physicians missing, it's the surgeons not accepting the patient. They want to wait for the lactate to rise. If the lactate is already high, which means it's already bowel is necrosed. So you have to convince your surgical colleagues that lactate will be normal in the early stages, and this is when you're diagnosing and it's the key and you catch them early. If you already have a patient with a high lactate, that means the bowel is necrosed. Nobody is going to be able to do anything. So thank you once again. Any other questions or comments, madam? Anand has always got his reading more than Tintinelli nowadays. So he's preparing for exam. He's preparing for exam, actually. Thank you, thank you, thank you once again.
Thank you all once again. Thank you, sir.
Thank you, Dr. Hari Prasad, for that insightful talk. Our next talk takes us into the unique challenges of high altitude medicine in the emergency setting. The topic is thin air, thick trouble, managing high altitude emergencies in the ED. Please join us in welcoming Dr. Jewel Rani Jose.
Dr. Jewel Rani Jose, MD, DNB, Emergency Medicine, Senior Resident, AIMS, Rishikesh.
So, hello everyone. I'm Dr. Jewel, Senior Resident from AIMS, Rishikesh. So, the topic given to me today is thin air, thick trouble, that is managing high altitude emergencies in ED. I'm sure that this is more of a theoretical topical for you people, because none of you will be working at such a situation. So, I think most of the people here are from Kerala, right? So, do you know what is the highest peak? What is the highest point in Kerala? Anybody? It's actually, yeah, it's Anambudi actually. So, the elevation is actually more or less like 2,500 to 2,600 meters only. It's not that of a very high, and then it's followed by Ponmudi. It's again a very low elevation. Then in South India, you have Mahabaleshwar and OT and Kodaikanal. So, again, these are like very low altitudes. I'm coming from Rishikesh, where our altitudes go up to even 1,100, 1,200 and 13,000 feet. Okay. So this is like bread and butter of us for the 6 months where they have the Chardham Yatra, the famous Chardham Yatra. So between the months of May to November, we get a brand of patients, like 80 to 100 patients per year we have to receive, and we'll be managing in our ED. So I'll start with just a case scenario. So a 42-year-old male was on a pilgrimage to a shrine located at an altitude of like 4,000 meters. The patient climbed to an altitude of 3,500 meters in a single day after arrival at the base camp at an altitude of 2,500 meters. At the night of arrival, he had complaints like chest tightness, shortness of breath, exhaustion, fatigue, improper behavior like feed refusal, like non-specific complaints basically. So nothing was done. He was managed at the base camp with oxygen and IV fluid. But the patients continued to deteriorate. So the next day, he was shifted from the base camp to a tertiary care center, and they reported that he also sustained an episode of seizure at the base camp. So what do you think? What could have gone wrong with this patient? So obviously this topic is high altitude emergency, so this is the first guess, obviously. But how many of you have gone for trekking? Only, sir, only you. Like most of the crowd is like between 20 to 40, except for our senior faculties there. So nobody has gone for trekking. I should say that you are wasting your youth. Trekking is something you should actually do in your young age. Okay. So what happens is at least you have seen people doing trekking, right? They have very big bags with them, and they'll have to climb their heights. So things which happens is that you will be not exposed to that kind of environment. That is, altitude is high, plus there will be hypothermia related changes. Your body will have to adapt to the altitude and with the hypothermia. Second thing is you will be having very heavy trekking bags. So you won't be having enough food supply or enough water or something to carry. So again, how frequently you will get time to drink water? There will be dehydration, you will be sweating. So there will be all these things going on. Plus, in high altitude, you all know that the oxygen concentration will be very low. So hypoxia is another villain there. So your body is going through all these things together. So anything could have happened to this patient. It might be even a simple dehydration, which have happened to our patient, which I discussed there. So this is actually showing peaks all over the world. And this is actually a kind of AI-generated picture which I have made for India. So you can see that the northeast and the Himalayan ranges. So the peaks is like 14,000 and 8,000 to 18,000 feet elevations are present in the Himalayas and the northeast states. So what happens when you go up? So FiO2, that is the fraction of inspired oxygen. Nothing much changes. Oxygen molecules are present everywhere. But the thing is that your atmospheric pressure is very low. So the effective number of oxygen molecules which you can inhale is actually very low. You can see that at the feet of 8,000 feet, the PaO2 levels are like 69 to 74. So that is the culprit for all of the manifestations of high altitude illness. So what happens? Our body is going through too much. So it has to do something, right? We have to survive. So human is all about survival of the fittest. So we have to do oxygenation and proper ventilation to keep us alive. So our body will be going through many adaptations. That is, we will be having a resting ventilation. We will be having something known as the hypoxic ventilatory drive. Third thing is the saturation of hemoglobin, then hemoglobin concentration in our blood, and the ventilatory acclimatization. So all these together will help us to acclimatize to the high altitude situation. So of these things, two most important things are hypoxic ventilatory drive and ventilatory acclimatization. So what happens is that normally our blood will be having a normal pH. You have reached a high altitude. Your oxygen level is very low. So what happens is that this decreased oxygen level is sensed by the peripheral chemoreceptors, that is a carotid body. What it does, it will go and stimulate the respiratory center. So what happens is, you will be having a hyperventilation. That is, you will be washing out your carbon dioxide. So you will be ended up having a respiratory alkalosis. So your pH will fall down. So this shouldn't go on like that, right? So this respiratory acidosis will act as a brake to the respiratory center. So by 2 to 3 days, maybe, our renal bicarbonate excretion and the renal pathologies for optimizing the pH will be coming. So the main thing is that hypoxic ventilatory drive means that when your oxygen is low, your minute ventilation can rise from a normal of like 5 to 7 liters to even 15 liters per minute. So that tidal volume, if you're inhaling more, then what happens? More oxygen will be inside. So that's what is the hypoxic ventilatory drive. Second thing is ventilatory acclimatization. So what happens is that if you go up and up and up and above, your body has to continue acclimatization. So what it happens is your carotid body will set its the set for the PCO2 at a lower level, so that you can continue this hyperventilation procedure without having much changes in your normal pH. So to say, initial phases will be dealt by the partial pressure in the oxygen, and if you are ascending to the height, then it is a partial pressure of the carbon dioxide which maintains your acclimatization process. So then there are many changes. In blood, you can see that EPO levels started to increase within hours, And basically, your oxygen dissociation curve, there is now much difference because there is increase in 2-3 dpg at one side and there is alkalosis at other side. So it is like more or less no significant changes. Then there will be peripheral vasoconstriction, there is suppression of ADH and aldosterons. So all these things will be happening in your body. So end result is that there will be barorespiratory stimulation called diuresis, then decreased plasma volume and a state of hemoconcentration. So who are the high risk populations? Like whom should you tell that you are going to ascend to a high altitude? So who should be careful basically? So patients with chronic lung disease and pulmonary hypertension. The thing is that hypoxic ventilator dive will be very low for these patients. So if they're going up and then exposing to a low oxygen saturation like environment, then they'll be having a risk of high altitude illness. Then atherosclerotic disease, congestive heart failure, and congenital heart disease with right to left shunt. Sickle cell disease, because again hypoxia will cause sickling, pregnancy, a recent patient with MI of less than 6 months, or if the patient is having an unstable angina. Again, these people are high risk. Studies show that stable coronary artery disease patients on optimal therapy can tolerate altitudes up to 3,500 meters, but not above. What about smoking? Anyone? Smoking? Like, will smokers be at high risk or not? Yes. This is actually a controversial statement because most of the studies say that smoking is actually protective. Okay, it's the reverse actually. So smoking actually is plus or minus, with most studies saying that smoking is a protective factor. Then hypertension is it's not a risk factor. So what are the high altitude syndromes? Basically, we have acute hypoxia, acute mountain sickness, high altitude cerebral edema, high altitude pulmonary edema, retinopathy, peripheral edema, sleeping problems, and neurological problems. So we'll be discussing only the main things here. So acute mountain sickness, it is characterized by headache along with a combination of symptoms like nausea, vomiting, dizziness, and all. So it's actually happening when the patient will be ascending to an altitude of more than 2,000 meters. So risk factors include sleeping altitude, the rate of the ascent, genetic predisposition, cardiovascular status, and all. So patients who are living at an intermediate altitude are actually partially acclimatized and they won't be having so much issue if they go up. So what is the pathophysiology? Again, at a high altitude, you will be having hypobaric hypoxia. It will cause cerebral vasodilatation. So there will be increased cerebral blood flow and there will be loss of CNS autoregulation. So this is the proposed mechanism for acute mountain sickness. So basically, if you see the symptoms, I'll be discussing in the next slide. It's similar to an ethanol hangover. So Saturday night you had a party and next day you're having a hangover. That kind of symptoms you will be having if you're having a acute mountain sickness. So the main thing is that it will develop between 1 to 6 hours usually. After ascending to a height, in a period of 1 to 6 hours, usually the symptoms will start. It can be delayed up to 1 to 2 days. And the average duration has been reported between 15 to 94 years. So lassitude is a very important symptom and it can be too much so that the patient required assistance for even eating or even changing the dress. So this is, don't ignore all these symptoms. These are actually very minute symptoms which are clues to say that your body is not adapting properly, so better to stop your further ascent. So what are the differentials? Differentials include dehydration, migraine, hypothermia, viral illness, and exhaustion. Carbon monoxide poisoning is something else, again, which should be overlooked. Because carbon monoxide poisoning, you know that in tents there will be hypothermia, so you'll be burning fire and all. So carbon monoxide poisoning is also a very important differential. So how do you diagnose? You have a Lake Louise acute mountain sickness self-questionnaire. These are the symptoms that I was talking earlier. You should have headache with GI symptoms, fatigue, weakness, dizziness, lightheadedness, sleeping difficulty or something. And there's a score that is 2 to 4 it's mild, 5 to 9 is moderate, and 10 to 15 is severe. So according to this, we can diagnose the acute mountain sickness. So how do you manage? There are 3 pillars of management. That is to prevent the progression. That is basically don't go up. If you're feeling any of these symptoms, halt your journey, you'll have to rest or better to descend. Second thing is acclimatization. So mild acute mountain sickness is actually self-limited. If you stay at the base camp for a period of like 36 to 48 hours, it will resolve on its own. So acclimatization is very important. Third thing is you have to treat the symptoms. So how do you treat the symptoms? There are again 3 things. That is descent, oxygen, and medical therapy. Descent, descent, descent. Descent is the single most important thing which can save your patient. You can tell that if the patient is having some kind of non-specific symptoms and all which we discuss, you can tell them that don't go up, you have to rest where you are. Because, and especially in elderly population, what happens is that people will be like, no, you'll have to descend, you'll have to descend. So they're already through a phase of physical exhaustion. If you're forcibly getting them down, again your body is going through exhaustion, which can actually accelerate the symptoms. So better thing is that tell them to stay at the same altitude for 1 day, followed by a gradual descent. So this is the better strategy. Second thing is oxygen. Oxygen actually quickly relieves the headache and the dizziness. So if you shifted the patient to the base camp, there you are having a medical care facility where oxygen was available, and you just give oxygen to the patient, his headache will be like gone. So that is the role of oxygen. Then again, medical therapy, you can try acetazolamide, which is a proven benefit. Then ondansetron and dexamethasone. These are actually adjunct medications. So anybody know what is this? It's written actually there. This is a gamma bag. That's a pressurized bag. So this is actually not available in India. So this actually can aid in decreasing the symptoms and can actually, instead of descent, like at the altitude itself, you can have a similar result to the descent. This is actually available at the Tibet and Everest and that kind of altitudes, but again in our institutes or like Rishikesh and the place where I work also, all these things are not available. So how do you prevent? First thing is graded ascent. What is graded ascent? Graded ascent means that after a after a period of 3,000 meters, for every 500 meters, you will have to sleep. Like if you have to ascend from 3,000 to 5,000, which means you will have a height of 2,000 meters. So 500 per day. That is over a period of 4 days, you should climb. That is what is known as graded ascent. So this is the best prevention strategy. Then things like you have to avoid overexertion, alcohol, and respiratory depressants. So there is a role of prophylactic acetazolamide for preventing acute mountain sickness. Then there are other therapies like ibuprofen, acetaminophen, aspirin, and medical therapies like ginkgo biloba. These are all like not an FDA approved, but again, there have been studies which showed benefit with all these drugs. So again, high altitude cerebral edema. If a progressive neurological deterioration occurs, or if the individual is having ataxia, then you can label that the patient is having high altitude cerebral edema. So what happens is, coma may ensure within 12 hours if treatment is delayed. This is very important. By the time patient will be shifted to you, patient might be comatose. So a delay of even 12 hours can basically have a neurological outcome. So this is very important for these patients. And persistent coma is usually unusual, and its present mandates occlusion of other causes of neurological deterioration. So differentials again include encephalitis, meningitis, stroke, subarachnoid hemorrhage, CVST, hypoglycemia, all these stroke mimics which we study. This is a classical finding which you can see in the MRI, that is the T2 intensities in the corpus callosum and the splenium. This is pathognomonic for a high altitude cerebral edema. Again, the treatment include descent, oxygen, and medical therapy. Here the drug of choice is dexamethasone, which is given as 8 mg start followed by 4 mg. It can be given in any form, that is peroral, intramuscular, intravenous, anyway. Even in this resort limited settings, if you're having tablet, you can give that. It will be actually very beneficial to the patient. So another case scenario, a 34-year-old male who is a smoker, who went to a truck, was rolled to the ER with a history that upon waking up in the morning, he is not able to move his hand and leg. His friend said that he was behaving very unnaturally since then, and he is not responding to us since 1 hour. So this is the primary survey. It looks normal except for the fact that patient is having a GCS of 12 out of 15, and he has positive movements on the left side. So adjuncts were done to the primary survey, ABG, ECG, everything was normal. So what investigation do you do next? Obviously, an NCCT head, because he had been symptoms like stroke. So we did an NCCT head, and this was the NCCT image. So anybody? These are actually juxtacortical hemorrhages, which are characteristically seen in cerebral venous sinus thrombosis. So CVST. So in suspicion of CVST, we actually initially thought this might be a case of high altitude cerebral edema because patient had a history of ascent to Kedarnath, then he had all these symptoms. So we were like, okay, this patient will be having high altitude cerebral edema. So we started him on steroids and all as soon as he arrived, but he didn't respond actually. We even given oxygen, there was no response. So that's when we shifted the patient to CT on urgent basis, and then we got this finding. We did an MRV for this patient, and it was showing that there is no opacification of the sigmoid and the transverse sinuses. So this patient finally ended to be having a cerebral venous sinus thrombosis. So next topic is high altitude pulmonary edema. Again, this is non-cardiogenic hydrostatic edema. So the fluid will be actually transudative. That is, there is no inflammation occurring. There is only the pressure differences. It's due to the increased hydrostatic pressure. So risk factors again are similar to the high altitude cerebral edema and AMS, heavy exertion, rapid ascent, excessive salt ingestion, use of any respiratory depressant, and previous history of HAPE is very important. This is a very documented risk factor which is not present for HAZE. Again, pulmonary hypertension and genetic susceptibility. So pathophysiology, again, hypobaric hypoxia is there. There will be pulmonary vasoconstriction, which causes increased capillary blood flow and pulmonary edema. So what are the symptoms? Initial symptoms will be like similar to an LRTA. You will be having dry cough, decreased exercise performance. So dyspnea will be initially on exertion. So the classical history will be that at the site where the patient will be having dyspnea on exertion, which progress to dyspnea at rest rapidly. So if you have this classical history, then you can label that probably this patient is having high altitude pulmonary edema. So later in the course, other findings like tachycardia, tachypnea, dyspnea at rest, all these things can ensue. And even the patient can present with the severe cyanosis. So the difference between acute mountain sickness and HAPE is that acute mountain sickness usually develops within the initial 1 to 6 hours. This will take 2 to 5 days. So initial day, patient might be asymptomatic. So this is noticed on or after the second night at a new altitude, that is 2 to 5 days. So what investigations can do? Because the patient might have a pneumonia, he might be having a pulmonary embolism. So anything can happen to the patient who is coming up with a shortness of breath. So this will need some kind of extensive evaluation. So in ECG, basically there will be a right heart strain pattern. So you'll be having right atrial deviation and right ventricular strain pattern similar to what is seen in pulmonary embolism. All those ECG findings you can see. Chest X-ray, it can progress from interstitial to localized alveolar infiltrates. And most commonly, they say that right side middle zone opacity. That is because of the hydrostatic edema and all. So right side middle zone opacity, if it is present, you can say that it's pathognomonic for a high altitude pulmonary edema. Then lung ultrasonography, I think most of you, all of you will be using in your EDs. So it's an accurate for the diagnosis of high altitude pulmonary edema. So there will be B lines which are like part of the interstitial syndrome. Then BNP and echo. This is actually in ruling out a cardiogenic component. So differentials, as I discussed earlier, it's like pneumonia, pulmonary embolism, myocardial infarction, any heart failure, mucus plugging, hypoxia, bronchitis. So the important thing is that key to successful treatment of HAPE is early recognition. If there is a delay, then probably your patient will deteriorate because HAZE has a mortality as high as 50 to 60%. So if you don't recognize it earlier, your patient can actually end up dying. So this is the X-ray showing a right middle lobe. This is actually generalized right-sided infiltrate. So treatment again is the same, descent oxygen. And in medical therapy, there is a role for calcium channel blockers and phosphodiesterase inhibitors. So there is no role of dexamethasone as such in this. So the role is for nifedipine, which is extended release tablets given every 12th hourly. And there are also some studies who says that inhaled salmeterol also have a role in the treatment of high altitude pulmonary edema. So how do you prevent, again, graded ascent, as I discussed earlier? This is the core thing. Secondly, for prophylaxis also, you can use nifedipine. So if the patient is having some of the risk factors which I discussed earlier, then you can give nifedipine as a prophylaxis. And also, phosphodiesterase 5 inhibitors like tadalafil, they are also used for prophylaxis. So the adequate discharge criteria for a patient with high altitude pulmonary edema is 2. That is, there should be clinical and radiological improvement with a PaO2 of 60 or a SiO2 of 90. If you have attained these targets, then you can discharge this patient. So last scenario for today, that is a 54-year-old male who is a non-case of hypertension and dyslipidemia. He was evacuated while on a pilgrimage to Kedarnath to a district hospital due to progressive respiratory failure. So you can see saturation is very low. It's 83% in room air. Respiratory rate is 32 per minute, and he has bilateral crepitations. Rest everything looks fine, and disability part GCS is like 14 out of 50. And in the ABG, you can see that the patient is having lactic acidosis. So this is the patient which you got. You did an ECG, and this is the ECG which you got. So what will be your diagnosis? Hypothermia, yes, Osborne J-wave kind of feature is there in the anterior leads, okay. What about the ST elevations? So is this high altitude pulmonary edema, or is this MI, or is this myocarditis? Sorry? The ST elevations are actually not global. You can see 2-3 AVF, there are ST elevations with typical depressions in the, like reciprocal changes are also present in V1, V2, V3. So this patient actually is a 54-year-old male. He has risk factors for coronary artery disease. That is, he had hypertension and dyslipidemia. And only thing is that he had a ascent to the Kedarnath. So only because of the fact that the patient ascended to Kedarnath, it's not that the patient is having high altitude pulmonary edema. This patient had typical ECG changes with reciprocal changes. We called up the cardiology team. They took the patient and he was having dual vessel occlusion. The patient, we shifted the patient for PCI basically. So exposure to high altitude may unmask coronary artery disease, left ventricular dysfunction, pulmonary hypertension that was asymptomatic at the sea level. This is very important. So then other high altitude syndromes, these are only for the completion purpose. There is acute hypoxia, will reverse with the oxygen. Peripheral edema can be there. It also resolves spontaneously with the descent. Bronchitis can be there because of cold air induced bronchospasm. Retinopathy can be there, which also will be resolving within 10 to 15 days. Important thing is the neurological symptoms. So what happens is that there are symptoms like altitude syncope, cerebrovascular spasm, thrombosis, and TIA and bleed. So what happens is that when you ascend up, blood flow to your brain increases. So three things can happen. One is space-occupying lesions. If anything was present previously, it can be revealed because brain volume will be increasing, your blood flow is increasing, it can bleed. Basically, a tumor bleed or something like that can happen. Second thing is hyperventilation. Hyperventilation can trigger or reveal a seizure disorder which was not present when the patient was at the sea level. Third thing is AV malformations. Again, due to high increased vascularity, AV malformations can bleed and cause symptoms. So this is actually very important, and you have to every time keep in mind whenever the patient is having a neurological symptom, it is not necessary that the patient is having a high altitude cerebral edema. Then again, sleeping problems. You know that if you will be staying at a tent, people will be there, people will be snoring, it's not your room, you're not in a comfy position. So there will be sleeping disturbances, which can again be troublesome. So again, acetazolamide has a role, that is low dose of acetazolamide. Usually for the treatment, we use a dose of 125 to 250 milligrams. So for the sleeping programs, the dose is 62.5 to 125 milligrams HS dose. So this can be used to prevent the sleeping problems. Then chronic mountain polycythemia, again, long-term residents or low landers who relocate to a high altitude may develop this condition after variable length of residence. So if the hemoglobin values will be very high, that is patient will be having polycythemia. As I said earlier, day one of ascent itself, your blood will be increasing your erythropoietin levels. But to get a frank polycythemia, it will take at least a minimum period of 3 to 6 months. So if the hemoglobin values are more than 20 to 22 grams, then it is recommended that phlebotomy should be done, because again it will be serving as a hypercoagulable state. So it is an indication for phlebotomy. And if severely symptomatic, you will have to advise them to relocate to a lower altitude. Or either otherwise you can supplement oxygen at home, like LTOTBU for COPD patients, you can ask them. But practically it's not possible to carry all those oxygen cylinders or something to the high mountain range, and that's actually practically not possible. Then again, there is a role of respiratory stimulants like acetazolamide and medroxyprogesterone acetate. So that's all, thank you. These are the 4 peaks which Yamunotri, Gangotri, Kedarnath and Badrinath, from where we get a brand of patients during the Chardham period. So any questions?
Thank you very much. That was a very comprehensive presentation on high altitude emergencies. So just to clarify, acetazolamide for sleep problems only at high altitude,
Yes,
not
sir.
for everyday sleep problems,
No,
right?
sir.
Otherwise, we might start taking that. Any questions?
BiPAP machine can,
Sir, actually,
because it will give PEEP. So
yes,
that
sir, you can try. It depends upon the severity of the symptoms. So what happens is, usually if the oxygen requirement is like 2 to 3 liter only, it will get resolved once you give the oxygen. Like there was an incident, we got a patient when I started my shift. The patient had a requirement of 4 liter per minute oxygen. When I started my shift, the shift went so busy that after 6 hours when I was giving handover, the patient's oxygen requirement almost was like nil. It resolved her tachypnea, all her symptoms settled down. So only with that oxygen supplementation for like 4 to 6 hours, the condition got fully reversed. That's how you diagnose the patient is having high altitude pulmonary edema also, the rapidity of response to oxygen. If the patient is having severe tachypnea or other indications for NIV, definitely we can give NIV, sir. And if needed, the patient GCS is low or there are contraindications for NIV, in some patients even endotracheal intubation will be required. So the thing is that how they manage things at the field, at the base camp. If they at least provide oxygen to this patient and they shift in an oxygen ambulance or something to a tertiary care center, the patient won't be that much sick. But sometimes what happens is that transport become very delayed in the remote areas. So patients will be coming to us very sick, so that we'll have to intubate only. Like even gasping kind of patients come to our hospital. So that we have to do accordingly, sir.
Ma'am, is there any target saturation that should be maintained? Like
90% they say, because even for the discharge criteria of a high person, they say that 90%, a saturation of more than 90% is enough.
Thank you.
Thank you very much. Thank you.
Thank you.
Any other questions? Thank you.
Thank you, ma'am. And finally, to conclude this session, we have an exciting talk titled Nitroglycerin Reimagined, Expanding Horizons in Emergency Care. Please join me in welcoming Dr. Diya Ann Verghese.
Dr. Diya Ann Verghese, MBBS, MD, Senior Resident at AIIMS, New Delhi.
Very good evening to everyone present here. I am Dr. Diya Ann Verghese. I have completed my MD Emergency Medicine from AIIMS Bhubaneswar, and I'm currently working as a senior resident at AIIMS New Delhi. So my topic for today's BREM is Nitroglycerin Reimagined, Expanding Horizons in Emergency Care. I'll be talking about the new paradigms, off-label uses, and the evolving role of nitroglycerin in the emergency department. So this is a slide showing the history of nitroglycerin. Nitroglycerin was used as a dynamite in the past. It was used by Sir Alfred Nobel in the making of dynamite, after which it became one of the earliest cardiovascular drugs. So why am I discussing one of the earliest cardiovascular drugs today? Why are we revisiting nitroglycerin? Even though it is one of the oldest drugs in emergency medicine, it is one of the most frequently underdosed drugs in the ED. It is often viewed just as supportive rather than decisive. It is a familiar drug with an unfamiliar potential. So let me take you all through a scenario. A 58-year-old male, known hypertensive, presents to the emergency department with acute onset respiratory distress, and his BP is 240 upon 130 millimeters of mercury, and he has pink frothy sputum, and he is very diaphoretic. So this is how classically a patient with sympathetic crashing acute pulmonary edema, SCAPE, presents to us. So my question is, do we intubate this patient, or do we reverse the physiology? We shall see. So what are we traditionally taught about nitroglycerin? When I initially joined my residency, nitroglycerin was started at around 10 micrograms per minute, and up-titrating it to 100 itself was a big thing. So we have followed a start low, go slow pattern for nitroglycerin in the past. It is used for the symptom relief of angina, and as an adjunct in acute coronary syndrome, and as a low-dose infusion in heart failure. We were just focusing on the safety aspect of the drug without realizing how urgent the condition such as SCAPE can be. So why does this paradigm not work in the emergency department? Patients of SCAPE in particular are acutely hypertensive, sympathetically driven, and time critical. Delayed hemodynamic control, as in the case of using low-dose nitroglycerin, can lead to early escalation and ventilatory support. And we could often vasodilate these patients, but we end up intubating these patients and ventilating them. So talking a little bit about the pharmacology of nitroglycerin in brief, nitroglycerin causes the release of nitric oxide, which activates guanylyl cyclase enzyme, which increases the cyclic GMP, causing myosin dephosphorylation, resulting in smooth muscle relaxation. So this is a dose-dependent function. At lower doses, nitroglycerin only causes venodilation and results in preload reduction. At higher doses, it also causes arterial dilation, hence reducing the afterload. Nitroglycerin has a short T-half of 1 to 3 minutes, and it is available in various formulations. oral, lingual spray, sublingual spray or tablet, topical or intravenous. So, like I said, dose defines the function of nitroglycerin. At low dose, it decreases only preload and causes due to venodilation, and at high dose, it decreases afterload due to its additional arterial dilation properties. It has a rapid onset and rapid offset, which makes it a titratable hemodynamic tool. So nitroglycerin is an apt drug for the emergency department because of its fast onset of action, predictable physiology, easy titratability, and rapid reversibility. Coming to the uses of nitroglycerin in particular, in the ED, for acute coronary syndrome, the AHA and the ACC recommend nitroglycerin as the first-line treatment, and the ESC recommends sublingual NTG for ongoing ischemic symptoms, or IV NTG for uncontrolled hypertension or heart failure in ACS. So the BP control in these cases results in ischemia control also. It reduces the myocardial oxygen demand. And if the pain is not controlled with sublingual, an IV infusion can be started. Make sure to rule out all the contraindications of nitroglycerin before starting it in these patients. So a sublingual dose of 0.3 to 0.6 milligrams every 5 minutes, up to a maximum of 3 doses, followed by, if there is no resolution, an IV infusion starting at 5 to 10 microgram per minute, and we can up-titrate it to a maximum of 400 microgram per minute. Make sure to monitor the BP. So coming to acute hypertensive heart failure, or the sympathetic crashing acute pulmonary edema, in which the primary problem is the excessive afterload, which causes acute left ventricular failure, resulting in severe work of breathing. So the therapeutic target of our nitroglycerin dosing in this patient should be in order to cause hemodynamic unloading. So it has been found that higher dose nitrates lower the rates of mechanical ventilation, intubation, improves the BP reduction, decreases myocardial injury, and decreases hospital stay and ICU admissions. Hence, higher dose IV NTG provides advantage over traditional treatment dosages. So coming to a little bit on the pathophysiology of SCAPE. So in these patients, there is sympathetic activation and vasoconstriction, due to which there is increased afterload, and this aggravates heart failure. So this causes fluid to rush back into the lungs, resulting in pulmonary edema. On the other spectrum, there is venoconstriction also. This shifts blood from the splanchnic circulation out into the lungs. And both of these causing pulmonary edema results in impaired lung function. And this patient feels very dyspneic and awful. And when the patient feels dyspneic and awful, it results in further sympathetic activation and vasoconstriction, hence causing this vicious cycle. So in order to treat patients with SCAPE, this is a cycle that we should break. So this is, on this topic, there are many observational studies done, but there are only 2 RCTs conducted in the world, and both of them are conducted in India. The first one was done in AIIMS, Delhi, published in the year 2024. So patients of SCAPE defined as acute onset dyspnea for less than 6 hours, tachypnea with a respiratory rate of more than 30 per minute, BP more than 160 upon 100, SpO2 less than 90% with bilateral crepitations, and diaphoresis or agitation were diagnosed with SCAPE. So in the high dose arm, according to the systolic BP, if it is 160 to 179, 600 microgram NTG bolus was given. And if it is 180 to 199, 800 microgram NTG bolus was given. And if it was more than 200 millimeters of mercury, 1000 microgram of NTG bolus was given, followed by a high dose NTG infusion starting at 100 micrograms per minute. And constantly, every 10 minutes, the patient would be reassessed. If the SBP is in the decreasing trend, the infusion would be continued at 100 micrograms per minute. And if the SPP remains same or is increasing, the NTG infusion would be titrated up by 20 micrograms per minute until the SPP starts decreasing and the patient symptomatically improves till the resolution of symptoms, any 2 of the below mentioned. following which the NTG infusion would be tapered and stopped. This was coupled along with non-invasive ventilation. So this RCT by Siddika et al. Showed that high-dose therapy was linked to shorter hospitalization, fewer 30-day major adverse cardiac events, and a trend toward lower intubation without an increase in adverse events. And there was better symptom resolution at 6 hours and 12 hours. So the consensus says that NTG infusion targeting a dose of 200 to 400 microgram per minute, or as repeated 2 mg IV boluses every 3 to 5 minutes can be tried for SCAPE. This is the RCT that was conducted in AIIMS Bhubaneswar. Patients in the high-dose arm was given NTG at 100 microgram per minute, and this was up-titrated by 20 microgram per minute every 10 minutes until the systolic BP reached 75% of the initial value and the symptoms improve, till a maximum of 200 microgram per minute, following which it was tapered and stopped. So we found that patients of high-dose NTG group had a statistically significant symptom relief at 3 hours. However, by 6 hours, there was not much of a statistically significant difference between the high-dose and the low-dose group. That means for rapid symptom resolution, high-dose and nitroglycerin infusion was beneficial. Patients of high-dose NTG group attained the systolic BP faster than those of low-dose group. And the patients of low-dose NTG group had higher episodes of intubation. And it is to be noted that no patient of the high-dose NTG group developed hypotension. So for SCAPE, we can follow bolus or rapid escalation strategies for nitroglycerin because it causes immediate afterload reduction and rapid symptom relief and a potential avoidance of intubation. So we focus on a physiology first care. So what is the most common fear when it comes to a high-dose nitroglycerin infusion? Everyone says that my patient will go into hypotension, so that's why they're scared of using a high-dose nitroglycerin. But the reality is that if a patient of SCAPE goes into hypotension, it is usually due to poor patient selection or inadequate monitoring or failure to de-escalate once the patient's BP decreases. So moving on to the next topic, the use of NTG in aortic dissection and aneurysm. It is used in the medically managed aortic dissection, that is the type B dissection. It limits the propagation of the false lumen, and it stabilizes the hemodynamic stress on the aortic wall. One thing to be noted here is that it should never be used as a monotherapy. It should always be administered after a beta blocker. Why? Because NTG can cause reflex tachycardia, and that can increase the left ventricular ejection force, and that can increase the shear stress on the wall of the aorta. In preeclampsia and eclampsia, the use of NTG is not well studied. But if preeclampsia is complicated by cardiogenic pulmonary edema, it is a possible option, not a first-line therapy yet. So in hypertensive stroke, encephalopathy, and sympathetic crisis, there is some emerging evidence that NTG may benefit to functional outcomes in hypertensive hemorrhagic strokes, but this is inconsistent evidence because the general belief is that NTG causes vasodilation and it can worsen the bleed and increase the ICP even more. So the routine use is not recommended. In cocaine-induced hypertensive myocardial vasospasm, NTG can be used. So some of the less emergent uses of nitroglycerin, it can be used in the treatment of anal fissures as a topical application. It reduces the sphincter tone. It causes rapid pain relief, which facilitates in both examination of the patient and in care. For esophageal food boluses also, it causes smooth muscle relaxation. It can be used as a temporizing measure. But this is limited due to lack of appropriate clinical trials. This is just a summary of whatever I have said about the dosing and the uses. So coming to the contraindications of nitroglycerin, the first contraindication is hypersensitivity to nitroglycerin. Recent use of phosphodiesterase 5 inhibitors like sildenafil or tadalafil within the last 24 to 48 hours. Angina caused by hypertrophic cardiomyopathy. Known history of increased ICP. Severe anemia, since NTG can cause methemoglobinemia. Right ventricular MI, because these cases are preload dependent, and venodilation can be catastrophic in them. Severe hypotension, that is a systolic BP of less than 90 millimeters of mercury, bradycardia, and tachycardia in the absence of heart failure are also contraindications. The most common side effect of nitroglycerin is headache. The most feared side effect of nitroglycerin is hypotension. And some other side effects are dizziness, weakness, palpitation, vertigo, nausea, vomiting, syncope, diaphoresis. In pregnancy, it is categorized as a US FDA category C drug. So the safety framework is that carefully the patients should be selected, and there should be continuous BP monitoring and a clear titration strategy, defined stop points, and bold dosing requires disciplined monitoring. Some of the cognitive errors that was seen in the use of nitroglycerin is underdosing, delayed initiation of nitroglycerin, and dogma-driven avoidance of escalating the dose, and over-reliance on ventilation than vasodilation. So I have finished 10 minutes in advance. I would like to just summarize some take-home points. Nitroglycerin is an old drug, but it has a modern role. The dose defines function. We should trust the physiology over tradition, and the thoughtful use of nitroglycerin can prevent invasive escalation. I would like to conclude by saying the future of emergency medicine may not lie in new molecules, but in deeper understanding of the ones we already trust. Thank you for your patient listening.
Thank you very much. I think you've summarized the uses of nitroglycerin very well. And underdosing and delayed initiation are the two biggest problems we have in emergency medicine. So be bold. Emergency medicine physicians should be bold to take decisions. Nothing worse can happen. Even if it happens, the patient is in the right place. Anybody got any questions? Einstein sir, any comments? Oh, you just entered. Doesn't matter. Well, emergencies don't come and they don't knock at the door. Even if you're entering, you must be.
Yeah, I'm having day
yes.
to day.
Gunaseelan and Anand always have questions.
In your experience of using NTG, NTG has a peculiar property of dose response. Like above this dose, it causes arterial dilatation, and below this dose, it causes venodilatation. So, are we commonly underdosing or are we commonly overdosing? What is your experience?
Sir, when I started my residency, we were commonly underdosing, sir. Because we would start at just 10 micrograms per minute, and then slowly, by every 10 minutes, we would increase it by 5 micrograms per minute. Then patient will be on 50 micrograms per minute for 24 hours. By then, the patient will develop tachyphylaxis, and then the drug would not have any effect. So we were commonly underdosing, sir. And right now, we are trying to increase. Sir, we have been starting at 100 micrograms per minute, sir. We can also give, so there are only 2 RCTs. In one of the RCTs, a bolus followed by a high dose infusion was started. And in the second RCT, only directly 100 micrograms per minute would be started without a bolus. In patients of SCAPE, I'm talking about.
Yeah.
And we would increase it up to 200 microgram per minute. But there are observational studies which have even used 800 micrograms per minute infusions and not noted.
Yeah, I use 400, 500.
Yes.
I use 3 sublingual nitros.
Yes.
Okay, that itself is how much?
15.
It is 0.4.
1500.
So it is 1200. 1200 in like in 15 minutes, right?
Yes.
So that itself didn't bring the blood pressure down that much. I am starting at 500. We can always decrease the dose.
Yes. If ever a patient on nitroglycerin develops hypotension, we can just stop the infusion and immediately the BP will catch
and they don't become hypotensive. That's the thing.
They cannot.
They have blood pressures like 220 or 140 and things like that.
Yes, sir.
And you can decrease, stop it. It's not. Yes. So you have to start with high dose, and you can rapidly titrate it down. That is the best way.
Yes.
CPAP and nitroglycerin. That's it. And we are like, within 1 hour, the patient is totally different.
Yes.
And the family is like, oh, yeah. He was like breathless, sweating, blood pressure high.
I
What
used
a
to-
miracle, doctor. That's what they will think.
I used to have this CKD.
Like, and
Sorry, sir.
initially the nurses say, I go and work in different hospitals. Not everybody starts like that. The nurses say, you want to start in this? Because they are not used to. I said, no, don't worry, I am here. Start it.
So
And they are like, oh. So that's what I'm saying. It's like, you have to experience,
So
I have never had any bad experience when patient blood pressure is that high and I am starting. Rapidly we will titrate it down and,
Till now, there has been no recommendation, sir, by.
Sir, how rapidly you titrate down?
It depends on the patient. No. We check recycle the blood pressure like every 5 minutes. Average it takes like 1 hour, more than an hour. Yeah, because because I am telling you, in 15 minutes, 3 sublingual nitroglycerin, you have given 1200 micrograms in 15 minutes. No, but sublingual goes directly into the blood. It directly goes into the blood.
Yeah, spray usually doesn't work because people, they most of the times, if you have people who are coming with GTN spray, it's out of date. It doesn't work. But sublingual works very well when you give it in hospital because it rapidly absorbs, goes directly into the circulation. So we have seen sublingual nitroglycerin even for people with chest pain works much better than GTN spray. So thank you so much. I think you've summarized it very well.
Thank you, sir.
And this is a topic which is not very commonly discussed in lots of conferences. I must say, the quality of presentations in this BREM talks, the 7 talks, has been exceptional. And I have learned quite a lot, very practical, very good key learning points. And this is something AEME has always strived to achieve. Excellence in EM academics. So well done, a pat to yourself, and a huge round of applause to all the presenters. Thank you so much for sharing your knowledge, for sharing your experiences, and for sharing your clinical acumen. And it is great that we keep learning. So always keep learning. The mantra is always keep learning and keep improving yourself.
I request the organizing chair and organizing secretary to please be on the stage. Ma'am and Dr. Jami, kindly please be on stage.
Ma'am, also, we are giving T-shirt to Ma'am and Jami also? Or?
No, Jami
No.
has it, but he wants to look as smart and dashing as he is looking now. So he says, no, don't give me, I'm unmarried. And Ma'am looks cute wherever. Well, she is happy person, happy soul. So please, ma'am, there is something. And I request Dr. Einstein, sir, and Dr. Venkat, sir, to first we will do a little token of appreciation for Jami. For his commitment, for his passion, for all he has done, being so young into this, I request Dr. Einstein and Dr. Venkat, sir, to please honor him with the fellow badge for AM.
Huge round of applause. I think he has worked tirelessly alongside Chandni madam to make this happen. And this is the fruits of all the labor
yes.
behind the scenes for several months. They have worked tirelessly day and night. And every time I message Chandni madam, even at 2 a.m. in the morning, she's responding. That means it's like 2 a.m. for her in the morning. So they have worked tirelessly. So huge round of applause and thank you so much for this great academic day. Well done.
Now everyone should stay back. If you allow me, I'll take the names. Means everyone who has contributed in these exceptional BREM sessions. The topics were there was a lot. There is a story behind all that. I would just leave it there. But I would just like to request ma'am, sirs, to please honor. It is on I'm just taking these names in the order they have presented in Hall 1 and Hall 2. So the topic on mechanical wall thrombosis, essential treatment modalities every EM physician should know, Dr. Anand Krishnan, KS. Kindly give him a huge round of applause. The take-home points were summarized so well. We have Dr. Vasudha D, ARDS Beyond the Books, managing refractory hypoxemia and making the right ventilation decisions. And we had Professor RK who gave all the good points on the ventilation beyond after that. It is another personal moment for me because Dr. Guglut Ramesh Babu would be joining us as assistant professor in Nizam's Institute of Medical Sciences. So my own colleague for the VOC code, vascular code in crisis, emergency approaches that matter. Another favorite of mine, Dr. Anusha SS, toxic alcohols. Can we rely on the osmolar gap? Rethinking diagnosis when history fails us. And she left us with few questions, and I'm sure we all will look back to it. The mountain girl, Dr. Joel Rani Jose, thin air, thick trouble, managing high altitude emergencies in the ED. Thank you so much for taking us through that. Dr. Hari Prasad, and I was very proud when his degrees were shown. And I'm sure you all must have also noticed, he expressed that he is also a fellow of AAME. FAME was there. So thank you, Dr. Hari Prasad, for that. And acute mesenteric ischemia, the CT angio that looks normal, and clinical gestalt that saves life. And thank you, Dr. Dia. Dr. Dia I met her very recently as an examiner, and this is her thesis. She did such a good work under the guidance of Dr. Upendra Hansa, nitroglycerin reimagined, expanding horizons in emergency care, new paradigms, off-label uses, evolving roles in the ED. Thank you so much. We go forward and we again move to the second hall, and I would request Dr. Arihant Jain. Dr. Arihant Jain has spoken about what lies beneath a practical approach to wound management in the emergency department. The first look to final closure include dog bites, tetanus-prone injuries. Thank you so much. Dr. Srijit. Dr. Srijit, he has not only done this BREM, he has also under the able leadership of his head of department, Dr. Jobin Jose, hosted our mass casualty workshop brilliantly. Thank you, Dr. Srijit, for that. Another list of favorites, yeah. Dr. B.L. Manish Kumar, he has talked about from coffee ground to code red, risk stratification and ED management of upper GI bleeds. Thank you. We have Dr. Vinayak SR following him with trust but verify, cognitive autopsy for better diagnosis in the ED. Thank you, Vinayak. That topic itself speaks volumes about your commitment towards and passion towards emergency medicine. Yeah, let's have a good round of applause. That's it. And then we have one of the favorites of many, and I need to hear the voice when I call upon Dr. Guna Seelan for stabilizing the unstable, the role of nerve blocks in emergency ABC management. And it won't be complete till I call upon Dr. Himanshi Bed, expert educator, I would say, and her journey in AME from attending it, just like Vinayak, she adds up to getting a first prize, to being an educator with us on Beyond Medical Management, Communication in Crisis. Thank you, ladies and gentlemen. Oh, I'm so sorry. Oh, I'm so sorry, Parvati. I'm very sorry. How I missed, I don't know. Yes. Sorry. Dr. Parvati on dangerous dysglycemia, management of glycemic emergencies in the ED. I should wear my glasses always. And what a wonderful CME this has been. A round of applause for all these educators, and I request all of them to please come together and let's have a BREM photograph. Thank you so much. Please come and let's have a BREM photograph. This photograph, please put it on your LinkedIn. Hey, Vinayak, you as well. We request Dr. RK and Madhavan sir also. Sir, we need your blessings. RK sir, we need your blessings.